really feel like patients urgently need access to information about cost, and they need to be able to have conversations about cost. And that's where this term and this idea of financial toxicity comes in. We really need to think about the financial burden that we place on patients, very similar to the way, or even exactly the way we think about other side effects, in the treatment and care environment. And as we all know, when you document and when you assess a side effect of a patient, you have an obligation to then manage and treat that side effect when it's present. And the same is true for financial toxicity. So cost of care conversations are incredibly important, not just giving access to the information so patients know what to expect, both in the context of decision making, so patients understand the differences between the choices they can make as it relates to cost, but also are able to think about that in the context of the planning for their treatment, understanding what are the financial pitfalls they should expect. But more importantly, and I'll share some more of this with you at the end of my presentation, so I'm sort of taking my own punchline away. But more importantly, patients want to know what's there to help them and how can they be helped. So it's our privilege at the National Patient Advocate Foundation to serve as the voice of the patients that we serve at Patient Advocate Foundation and really elevate issues like these to a national stage, both in the policy sense, but also in the larger health system sense. So we've had a great opportunity to work with Robert Wood Johnson Foundation and several other partners that I know Gwen will talk a little bit more about to really think about this aspect of the healthcare system, cost of care conversations, and how to really infuse it into the normal flow in a way that's meaningful to patients. And I'll share some data that we've collected about what's the patient experience currently around cost of care, as well as what are some of their preferences as to how they'd like to get that information and how they would like to use it. So I'm going to turn it over to Gwen just to finish the introductory remarks this morning. She's our EVP for Patient Advocacy. I know Gwen probably knows more of you in the room than others. So I've enjoyed watching her say hello to everybody as the Master of Ceremonies this morning. So Gwen, please, welcome to the stage.
Thank you, Alan. Good morning, everybody, and thank you so much for being here with us. And Alan, you're going to have a real treat when you see some of the data that Alan's going to present. First of all, I've never seen anybody who loved to present data the way Alan Balch loves to present data. He gets so excited. And the way that I like to talk about stories, he likes to talk about data. So I do have a couple of slides just to set up, we don't need to look at our pictures anymore, just to set up what we're doing today and give you a context for the kind of the flow of the day. So as Ellen mentioned, this is part of a project, and this is actually the kickoff, or the second kickoff, because we did a webinar, the big kickoff of our project on cost of care and conversations about cost of care. And we are focusing on a number of things that are really important to look at. And I think, the framework for all of this is that it's untenable to separate cost of care discussions from making care decisions and doing true shared decision making. And one of the things that I was thinking about when I was wandering around my various rooms in different ways, that's how I write things, I walk around the room in my head, was that we have to make sure that when we do this, that it's not just another box that we check on the EHR, did you talk about cost, but that it really becomes embedded in how we care for people, because there are many, many different ways that we can choose to care for people, and there are often many options, sometimes there aren't. But if we don't think about cost, and if we don't think about cost beyond the idea of cost being just money, and we're going to hear from a number of people around that, we're really not going to impact the healthcare of our society. And so we'll talk about cost from an individual level, we'll talk about cost from a family level, we'll talk about cost from a regional level, and we'll talk about the cost impact on society. We'll talk about healthcare costs, we'll talk about opportunity costs, we'll talk about costs to the interruptions of our lives. Suleika and I are going to have a conversation about that as young adult cancer survivors. And we're going to talk about some solutions. So the first panel will really focus on why we need to have these conversations. And we're not just going to talk about why, because everybody knows why, but we're going to delve deeper into the why. What is the harm that can be caused by not having these conversations, and what can we do to improve the health of people, in the health of our family, friends, and fellow community members by having these conversations. The second panel, we're going to look at some of the projects that have been done around integrating the cost of care into the patient life flow and the clinician workflow. And I think you're going to be there have been some extraordinary and creative responses to those, and you will hear from some of the people who have worked on that. This is a project, as I mentioned, Robert Wood Johnson Foundation funded and driven. There were a number of grants that were given for, I think this is in your packet, that were given about research around cost of care conversations, and then following that, in the best tradition of Robert Wood Johnson Foundation, they said, we can't just have this research, we also have to figure out how to disseminate it and how to engage the key stakeholders. So there's 3 key stakeholder groups that are working on this. There is America's Essential Hospitals, and we have Jerry Krishnan, who's representing that group on the first panel, American College of Physicians, and we have April Barber on that group. And we also have Avalier, who has worked in partnership with the Robert Wood Johnson Foundation from the beginning. One of the things that I love about our policy consortium, and I was talking about it to some people last night, is that we always have a really diverse cross-section of stakeholders in the room who are the stakeholders that are the ones that really can affect change. And as Alan mentioned, our PAF and NPF work at the intersection of direct patient services and system change, and this exemplifies what we're doing in that area. So we're going to have an opening talk and then conversation from Suleika Jawad, and I'll introduce Suleika in a minute. Then we will have a conversation with Liz and Tom Ema, and Liz and Tom Ema, they have a phenomenal story, and I don't want to give their story away. Alan is going to present data and do a little data dance. And then we have our first panel on why cost of conversations. Then we have a great lunch speaker treat. Peter Ubel is going to talk about cost of care conversations. He's a physician and a behavioral scientist. Pardon me? Behavioral pseudoscientist. So you're going to hear some pseudoscience, which we always like to present in these meetings, and then we have a second panel on some of the ways that people have integrated cost conversations. So I want to thank everybody for coming. I also want to particularly thank the Robert Wood Johnson Foundation and our colleague Emmy Ganos and then Anya Frazier for really taking an incredibly a really visionary and innovative leadership role in all of this. So without getting too far off schedule, I just wanted to talk about the few things that we're going to explore. We're going to explore cultural taboos and assumptions that inhibit talking about money. And they're much broader than I think most people think about. What keeps people from talking about money, and what people assume is going to be the impact and the result of talking about money. It's not just about what keeps them from talking about money, but what people are afraid will happen if they talk about money. And then the culture of the different stakeholders who are part of that. We're going to talk about investigating patients' attitudes about what they think the role of their healthcare providers are in this conversation. And we know, those of us, we're all patients and we're all caregivers, that it has long been received wisdom that doctors have no business talking about money. And it is that cannot happen in order to treat people effectively. And then we're going to look at the lack of transparency in cost information and the barriers to cost conversations in the clinical workflow. And I just want to make sure that we always add in, when we talk about clinical workflow, that we are talking about the patients and family life flow, because if we only think about clinical workflow, we're missing everything that goes around that clinical workflow. So we are going to start with a very special treat, a presentation from Suleika Jawad. And Suleika is going to, we're going to show a video first, and then Suleika will come up and talk. I imagine that many of you have seen the series that she did in the New York Times called Life Interrupted, and it was about being diagnosed with cancer as right out of college and what that meant. Not only what she experienced, but what that meant. And I think that is a significant differentiator about the way that a lot of people write about their experiences. They write about what happens, but they don't always write about what meant. And so she did an incredibly honest, forthright, thought-provoking, thoughtful series, and we are just so pleased to have her. And so I'm going to, Suleika will come on the stage after the video starts, and so whoever is supposed to cue the video, can I ask you to do the video?
Cancer doesn't just put your life on hold. It's not like you get to skip back a few months and pick up exactly where you left off. I wasn't going to get my old life back. Being in your early 20s is a strange thing to live with a life-threatening disease. And I remember as he said the words, acute myelogenous leukemia, it felt as though he slapped me across the face.
She said they've scheduled the bone marrow biopsy for Friday.
When I was first diagnosed, I think I felt pretty terrified. I'd never really seen anyone who was very sick.
So we'll be back. When should I expect to have the results of my bone marrow biopsy? Probably.
And the more ill I got, the more isolated I began to feel. I think part of it was that I had never really experienced physical pain. I've never even broken a bone, so coping with that was really shocking.
I don't know. I don't know words for it. It's just, I feel like I'm the mother. I need to be holding myself together. If you're a parent of a child is one thing. As parents of a young adult, you have to be careful. We still want to do everything for her. But you learn that doing everything for her, or to have her, is not necessarily what she wants. So you got to learn to step back and to be useless and accept it. And it's very hard.
This is the best one? Yeah. I used to be so afraid of needles.
Really?
Even through the first few months of my treatment. I still am
But
sometimes.
now you're used to it already.
Now I'm used to it. I still can't look though.
Yeah, don't look.
So when I found out that I would need 6 months of chemotherapy treatments and move permanently into my childhood room, I felt really angry. The goal had always been to learn how to be sort of an independent adult in the real world. And suddenly everything that I had worked for had vanished. My apartment, my independence, my job, everything. I wouldn't say that cancer is a gift, but I've learned a tremendous amount from going through this. My priorities are different. My goals for the future are different. I see the world differently. I see myself differently. For me, initially losing my hair was a pretty traumatic experience. I felt unattractive, and I felt like I was losing a part of my identity. I'd always been a girly girl. I liked wearing dresses, I liked wearing high heels, and when I lost my hair, subconsciously I started embracing this new, edgier aesthetic. I've basically put all of my peasant dresses in storage and have adopted a leather jacket and boots with spikes on them. Here we go. You know, people look at me very differently to how they looked at me before when I had long hair. And I really feel tougher and a little bit braver. Ah, much cleaner. In these many months of sitting in bed, I've discovered that I really love to write. But before I got sick, I never felt brave enough to actually put myself out there. So I started a blog, and all the thoughts I'd been having for the past year and all of these experiences just kind of came flooding out. Up until that point, I'd kept my story very private, and suddenly I had this new support system that had kind of formed out of nowhere. When I was first diagnosed with leukemia, I found out I was also going to need a bone marrow transplant. My transplant is my only shot at a cure. And now that it's so soon, it's becoming increasingly difficult for me to block out all the risks and all the fears. I think I'm also just tired. My body's tired. I feel like I've suffered a lot physically in the past year, and the idea of going through something that's going to be even more intense than anything I've experienced before scares me a lot.
Hi, everyone. Good morning. My name's Suleika Jawad, and I am a cancer survivor. I'm also a journalist and wrote the New York Times column and video series Life Interrupted, where I chronicled what it was like to live with cancer for the better half of my 20s. The name of my column was Life Interrupted because that's what it feels like to be a young person and to get cancer. It's an interruption of everything you knew before. At the time, I was 22 years old, and my adult life was just beginning. Less than a year after walking across the stage at my college graduation, my doctor sat me down and uttered those 3 words you never want to hear. You have cancer. After nearly 6 months of being misdiagnosed, a biopsy showed that I had a rare type of bone marrow disorder called myelodysplastic syndrome, and that by the time of the bone marrow biopsy, it had turned into acute myeloid leukemia. At the time, I was living abroad in Paris, and overnight I lost my job, I lost my apartment, and probably worst of all, I lost my independence. And I moved back to my parents' house in upstate New York, into my childhood bedroom with its pink walls and embarrassing posters of boy bands taped to the walls. And I prepared for my new team of oncologists to come up with a treatment plan. Getting cancer at 22 seemed to magnify the in-betweenness of young adulthood. I was a year too old for pediatrics, but decades younger to a lot of the other patients in the adult oncology ward, and I didn't fully feel like an adult yet. For my friends and for my classmates, this was an exciting time as they started new jobs and traveled the world and went to parties and dated and all the rest of the big and small milestones of early adulthood. But for me, my diagnosis had forced me to hit the pause button on my life and on my career before either of those things had really begun. At the same time, I had no choice but to grow up fast. Daunting questions that I hope my peers won't have to consider for many, many more years became my urgent everyday concerns. Will I live long enough to go to graduate school, to get married, to have a family of my own one day? How will I hold on to my health insurance or pay for my treatments if I'm not well enough to work? Like a lot of recent college graduates, I never really thought about my health or health insurance, for that matter, until I got sick. From early on, my new team of doctors told me I'd need chemotherapy and a bone marrow transplant in order to have a shot at a cure. But before the shock of that diagnosis could settle in, before I could consider where and how I would receive my cancer treatment, I did what most Americans have to do when they're faced with a medical crisis. I called my insurance provider. I have to confess that I knew nothing about health insurance before making that call. I was 22 years old, after all, and I didn't exactly know what the word premium meant, and copay sounded to me like what happens when friends split the tab at the bar. Certainly, the term lifetime limit had never crossed my mind until then. The last time I could remember getting sick had been a 2-day bout of food poisoning during my junior semester abroad in Egypt. Now, I was facing leukemia, and I was beginning to get worried about coverage from an insurance plan I knew virtually nothing about. This was my welcome party to the wide, complicated world of healthcare in America, and I wasn't alone. If you're living with a chronic illness or a life-threatening disease in the United States, there's a good chance you also hold a degree in Health Insurance 101, whether you want to or not. The first thing I learned was how lucky I was to have health insurance at all. Thanks to the Affordable Care Act, I was incredibly fortunate to be able to stay on my parents' insurance provided through my dad's job until the age of 26. Because of how complex and advanced my leukemia was at the time of my diagnosis, I didn't have the option of being treated locally in upstate New York, where my parents lived at the time. What this meant was that we would have to make an 8-hour round-trip commute several times a week to New York City for me to get the care that I needed. Eventually, as I got sicker, my mom, who was my primary caregiver, and I would have to relocate to New York City altogether. I was lucky to be able to receive treatment at world-class hospitals like Mount Sinai in New York City, where I did my first chemo protocol. And when that didn't work, I enrolled in a phase 2 experimental clinical trial, followed by a bone marrow transplant at Sloan Kettering, and what would end up being 2 additional years of chemo. During the 3.5 years I spent in treatment, my insurance covered nearly $3 million in medical expenses, including the transplant, the chemo, the clinical trial, and over 20 emergency hospitalizations, amounting to a combined 8 months of inpatient care. It all sounds pretty straightforward when I explain it like that, but even if you have good health insurance, like I did, the cost of healthcare in dollars, as well as in time and stress, is still incredibly overwhelming. Every time I saw a doctor, got a CT scan, received chemo, or picked up a prescription, insurance covered only part of that transaction, and there was always a bill on top of it. For a patient like me who took over 30 pills every day and visited the hospital on a weekly basis, and that's if things were going well, I seemed to owe another payment each time I blinked. Keeping track of how much I owed and for what procedure and why still makes my head spin just thinking about it. Learning the ins and outs of an insurance plan's coverage takes sustained, persistent attention and energy, things that sick people have in short supply. Another cost of my cancer care was time. My mom graciously took on the task of disputing claims, keeping track of bills, requesting approval for a procedure or a drug, and spending countless hours on the phone with my insurance provider. And while all of this was a labor of love for my mom, working out the financials of my cancer treatment was also a whole lot of labor, plain and simple. Between the long hours spent taking care of me and dealing with our insurance, my health care became her literal full-time job. She took 2 years off of work to take care of me, a financial and professional sacrifice that was due in part to the incredible amounts of time it required to navigate not just the treatment of my cancer, but the cost of it. My mom would have done anything for me, but I also remember wishing she could have spent more time with me and less time with my bills and on the phone with my insurance provider. I met plenty of other patients in treatment who weren't as lucky and didn't have mothers or family or friends there to support them, and I can't help but wonder how my outcome might have been different without a full-time caregiver helping me with all of that. Over the years, the out-of-pocket costs associated with my treatment, co-payments, out-of-network charges, the cost of fertility treatments not covered by insurance, the cost of moving to New York City for the transplant, the cost that came after the end of treatment, and the secondary side effects and complications that I had, like graft versus host disease and a thyroid condition and any number of things, have cost me and my family hundreds of thousands of dollars over the years. The financial burden of my cancer did not mean that my parents had to get second jobs or that we had to sell our house, although I know of fellow patients with and without insurance who have had to consider such options. Sick people don't plan on getting sick, and they shouldn't have the added worry that someday insurance coverage may not be there or that a medical crisis could become a financial emergency as well. But I've seen firsthand in my own experience and through my work and through the stories of fellow patients in the cancer community that access to quality, affordable, coordinated care in the U.S. is still a big problem for patients with and without insurance. And I've seen how patients end up in impossible situations where they have to make decisions between things like life-saving medical treatment and rent and groceries and paying their heating bill. I think it's easy to be discouraged when you work in cancer research or in advocacy. You don't always see the results of the work that you do firsthand. But I'm alive today because of a phase 2 experimental clinical trial and a bone marrow transplant made possible by that research. And I'm alive today because of a brilliant team of doctors and nurses and social workers, and because of policies and laws like the Affordable Care Act, without which none of the treatments that I just mentioned would have been possible. But more than anything, I think I am alive today because of a community of patient advocates like this one who care and who act on that caring. This summer, I turned 30, and I celebrated by running a half marathon, something I would never have dared dream of long before I ever got sick, because I was one of those kids who couldn't even run the mile in gym class in high school. And I feel incredibly grateful to be alive and to be cured of my leukemia. For the first time in a very long time, I've noticed that there are entire days, sometimes maybe even a week, that go by where I don't think about cancer and I don't think about everything that I went through. And I feel healthy and I feel strong. And for the first time in a while, I feel hope when I think about what the future has in store. So I want to thank all of you so much for inviting me to share my story and for coming here today and for the incredible amounts of time and energy you put into making sure that patients, regardless of who they are or how old they may be or what background they're from, have access to that same kind of hope. Thank you. Thank you. Thank you. Thank you. Thank you. All right. Is this on? Yes.
Oh, yeah, I think we have to turn this on. There's a button. This one.
Yeah.
Am I on? No.
Let me see.
Do you have any? Oh, this button. There are
There you
two
go.
black buttons. Sorry. I certainly ruined I certainly ruined the atmosphere after that by having problems with my technology. Suleika, thank you so much for sharing your story. And we're just going to talk a little bit about some of the things that came up in her story And then I'm going to invite any questions anybody has from the audience. We've got about, we're running a little behind, but we assumed we'd run behind, but we have got about 20 minutes total to talk about it. So one of the things that, so as most of you know, I'm also a young adult cancer survivor, not a young adult anymore, but I was, but on the other spectrum. So I was 35. And I think one of the things that is always underestimated when we talk about the cost of cancer is really the cost of what happens to you and what you lose and the opportunities that you lose, both you and one's family. And I think that that's why the title of your series, Life Interrupted, was so evocative. And it is, there is an incredible interruption and an incredible cost to all of that that has lasting effects. And so I'm wondering if you could just talk a little bit now that you're 30, yay! When I turned 40, I was so excited. I have never thought I'd be excited to turn 40, and now I'm older than that. But I think that people really underestimate that. And I think if we're really looking at holistically how we integrate these conversations, we can't just think about what we end up in debt for in terms of our medical costs. It's also the cost of daily living.
Yeah, I think, young adults have always been an especially vulnerable patient population on a number of levels. They're one of the few patient demographic groups whose survival and cure rates have not improved in the last few decades, unlike adult patients and pediatric patients. And before the Affordable Care Act, they were also the largest uninsured population in the country because, youth and health are supposed to go hand in hand. And as someone who, when I graduated from college, was living, I never forget my first apartment right when I graduated was in New York City on Canal Street, and I had 10 roommates. And so, when you're 22 and you're figuring out what you want to do and who you are, who it is that you want to be in this world, and you're struggling and you're, waiting tables or whatever it is that you're doing to kind of make ends meet, the thing that you're probably not going to invest in unless you've been sick before is your health insurance, and you're going to get the cheapest plan if you get a plan at all.
Yes.
And that was certainly true of me. I never, spent the night in a hospital. I never even broken a bone until I got my diagnosis. I think the other thing to consider is, for me, I graduated with hopes of becoming a journalist. I wanted to be a foreign correspondent in the Middle East, which is where my family's from. But I didn't quite know how I was going to do that. And so I, got a job as a paralegal, and I was babysitting in the evenings, but I didn't have an actual career yet. I had an aspirational career in my daydreams, but I didn't have a career. I didn't have a savings account. And I think that, when you talk about the cost of care, you also have to look at where a patient is starting from. And so when I entered the hospital to begin chemotherapy, I didn't relate to my roommate in the hospital that first week, who was 65 years old and who was retired and had children. I was still figuring out all of those things. I didn't have a family of my own. I didn't have a savings account. I didn't have a retirement plan or much of a plan at all, for that matter.
Yeah, thank you. It is losing a few years of your life is a significant cost and a significant impact. The other thing that you reminded of us of in your talk was about the impact on your family and the impact on your mother, because we think about the financial costs and the sacrifice. Often we focus very much on the patient, but this was a family sacrifice.
Yeah. It doesn't matter how many fancy degrees you hold or how educated you might be, when you're really sick and you're on a lot of morphine, you're not in a position to advocate for yourself, let alone to go through piles of paperwork. And so I thought about that a lot because, you know, there were so many things that were over my head, and you can't underestimate the overwhelm factor for patients when they receive a cancer diagnosis. My first stint in the hospital, I spent 2 months inpatient in isolation. And even though the hospital was in network, it turned out that not all of the doctors who worked there were in network. And so on any given day, I would have some days up to 30 different people coming into my room. I'd have a palliative care team, I'd have a psycho-oncologist, I'd have the attending doctors. And what we didn't know then, but we quickly learned when I was released from the hospital, was that we got, you know, a stack this high of bills from doctors who are not in network. And what do you do with that as a patient? Do you put up a sign on your hospital room door? Do you, as a patient who's in excruciating pain, you know, stop the palliative care team and say, excuse me, before you give me my morphine, are you in network? No, of course not, right? You're totally overwhelmed and you're suffering and you need treatment. And without my mom, who managed to spend, hundreds of hours disputing every individual claim that we got like that, I would have been who knows how much in debt. But I know for certain that I wouldn't have had the energy or the wherewithal to dispute all of those claims. And that's just a small example among many of the ways in which having a full-time caregiver when you're really sick isn't just helpful, but necessary.
So we're going to talk to the EMAs a little bit. You're going to hear their story, and they're going to talk a lot about many of the same issues as you. And we're also going to hear from Rita Matthews, who's one of the PAF case managers, and she'll talk a bit about how she works with patients when they're sort of facing overwhelming activities. But I think there are two things that are really critical here. I was really struck by the fact that you said that you would have much rather, it's so obvious, but we don't talk about it as much. You wanted your mom to spend time with you. You wanted a mother-daughter relationship. You did not want a relationship with somebody who is your insurance case manager.
Right.
And as we look at policy and as we look at things that we can have action on and what we can, where we can take this, I think one of the things we really have to talk about, and we do a lot of work around this at Patient Advocate Foundation and National Patient Advocate Foundation, are these out-of-network surprise billing, this notion of the complexity of insurance. And as Alan mentioned when he did his introduction, we have the most complex medical system in the world. We also do not have very good uniformly good outcomes, which is another. So the complexity combined with pretty poor outcomes across the board, if you average everybody in, is not acceptable. It's absolutely not acceptable way to go. So it is. I just can't even imagine what it was like for your mother and your family and you, because as a young, I'm losing my voice, as I know how isolating it is to be a young adult cancer survivor. It's terrifying. You wake up in the middle of the night, you don't know, nobody you know is going through the same thing. There are just, so that kind of, the moving of the person who should be emotional support or the people into being your insurance support seems to me a tremendous cost and impact of a diagnosis.
Hugely. And, one of the first things as a young adult that happens when you get a diagnosis, especially if you're going to have chemotherapy that is going to leave you infertile, and you haven't yet had the chance to think about things like becoming a parent. In fact, like the most thought you've probably given to babies is specifically how not to have one before you're ready, right? But one of the first things that I learned as I was not only wrapping my head around the diagnosis, but around this infertility piece, is that before even I began chemotherapy, I had to decide if I was going to take the time to go through fertility preservation options. And once I decided that that was something that was important to me, I then learned that the fertility preservation treatments, which can cost upwards to $20,000, were not covered by my insurance. And the reason they weren't covered was because I technically wasn't infertile yet, even though I would be in about a month. And so it was considered an elective procedure. And so I was lucky, thanks to my nursing team and to an incredible social worker, to get a grant through an organization called Fertile Hope. And they wrote a check and they offset a huge amount of that cost. But I know of so many young adult patients who, before they've even begun to wrap their head around things like chemotherapy or radiation or surgery or whatever it may be, have to make a decision that hugely impacts their future. That's a financial one. One of my very best girlfriends who I met in treatment decided not to do fertility preservation treatment because she couldn't afford it, and the thought of the cancer treatment and paying for that was already daunting enough. But when you think about outcomes and when you think about mental health and mindset going into treatment, these are all the things that even before you begin as a patient, you're trying to hold in your head, and you're trying to make sense of. And it's a lot, and it's really hard, especially for the many patients who don't have parents who are able to take time off of work or to be their caregivers. Yeah.
No, when I asked my oncologist about fertility, because I was 35, so I was on the cusp, he said, "Oh, we're not going to worry about that now. We just want to get you better." I'm like, "Okay," and sort of patted me on the head. So one of the things, so there are two things I just wanted to ask you about, and then I want to open it up to see if anybody has any questions in the audience. One of the things that you talked about was being able to access care through clinical trials, and it's something that we do often through our case management, is that can be one of the options that we help people investigate. And it can be very burdensome for an individual, but it also can be incredibly life-saving for an individual.
So when I entered the hospital, I had 30% cancerous blasts, they call them, in my marrow. And at the end of that first, intensive month-long hospital stay where I did chemotherapy, the number of blasts in my marrow had more than doubled to 70%. And what that meant was that the standard chemotherapy treatments were not working for me. I was going into bone marrow failure, and I was almost entirely reliant on blood transfusions. And that's around the time when my oncologist started talking to me about something called a clinical trial. It probably seems naive to all of you, but I think it was the first time that I understood that I might never be cured and that this might be it for me. So I went into this trial with a lot of fear and a lot of anxiety. I also didn't quite understand what a trial was. I thought it was a kind of last resort option, and I imagined, like mad scientists experimenting on guinea pigs in their basement labs, and I didn't want to be one of those guinea pigs. And I had a lot of angst going into it. But my doctors were really wonderful, and the clinical trial nursing team was incredible, and they spent hours and hours and hours with my family going through the paperwork. There's a tremendous amount of paperwork that can feel really overwhelming, and explaining to us what a trial was and how it worked, and trying to make the experience as livable and as feasible for us as possible. At the time, I was still commuting back and forth between upstate New York and New York City. And that geographic barrier wasn't just inconvenient, but it became dangerous as I got sicker and as I started to, have complications from the treatment that ranged from neutropenic fevers because I had no white blood cells to sepsis and all kinds of things. The toxicity of the actual drugs was pretty extreme, and I almost dropped out of the trial at a couple of different points. But I think the financial toxicity of the trial, even though the cost of the trial itself was covered, was also very burdensome. And what that ended up meaning for us was that we had to move to New York, which is not a small thing. I have a brother, and my dad and him stayed back in upstate New York to kind of hold down the fort, and my mom and I relocated to Manhattan. And thanks to friends who opened up their guest bedrooms to us and to the Hope Lodge, which is funded by the American Cancer Society and where I lived for nearly 3 months, we were able to make that work. But in spite of all that support, it was still an incredibly difficult and stressful year before I even entered into the transplant process. So that was my experience with the trial. I think, now looking back, of course, I can confidently say that the trial not only was the best option for me, but it actually saved my life. Within 8 months, that blast count that I mentioned had dropped from 70% to under 5%, which is pretty incredible. And as a patient, it's always strange to think that if you'd been diagnosed even just a few months or a few years earlier, you might not have had access to those cutting-edge trials, and that without that, you may not be here.
So I'd like to see if anybody, we have a few minutes, and I wanted to open up to the audience to see if anybody had any questions for Suleika. Chris.
Yeah.
You mentioned all these out-of-network bills and sort of being blindsided. Was there ever any discussion with your treatment team or your physicians that allowed you to anticipate any of this, or did you really find this out when the bills arrived?
So it's difficult for me to know, and my mom was the one who was fielding a lot of this. But from what I understood from her, she very much felt blindsided. There was certainly during that first hospitalization, there was no mention whatsoever about the in-network, out-of-network confusion that arises when you're a patient who spends a lot of time inpatient. That learning curve was steep, and she very quickly had to get savvy about how to handle that. And I think at that point, she reached out to the social worker at the hospital for help with figuring out how to navigate all this. And I think at that point, the social worker and other members of my medical team sat down with her and, explained to her how you can write a letter and you can, all the different ways that you can contest and dispute some of these claims. But that initiative had to come from her. And I think there are a lot of patients who not only feel intimidated by their doctors, but certainly feel intimidated by the healthcare system at large. And when you get a letter saying you owe this much, they're not necessarily going to question that. They're not necessarily going to think through, why that might be, and what kind of wiggle room there might be. And so I think, to answer your question, no, we did not feel prepared for that. But once my mom took the initiative, she was able to kind of piece together various support systems and different members of my medical team to help her. Yeah.
Oh,
So have you, since
you're getting a microphone.
Thank you. I was just curious if through your writing you've been able to do anything to raise awareness about clinical trials, because general public awareness is pretty abysmally low, and I would suggest that maybe among young adults it's even lower.
Yes.
So I just wondered if you'd been able to use your writing as a vehicle for helping people understand what these are, and that you're not a guinea pig in some mad scientist's basement.
Yes, exactly. Yeah, I've written quite a bit about the clinical trial experience for this very reason. I think there's a lot of misunderstanding, a lot of superstition, and a lot of fear. And it's interesting because from what I understand, in pediatric oncology, I think something like 70% of pediatric patients are enrolled in trials, whereas with adult patients, it's something like 3 or 4%.
Yeah.
And so I don't quite know why that disparity exists, but it's something I've been interested in, and that I've done a lot of speaking around and a lot of writing about, and that I'd like to continue to explore. Yeah.
So, final question from Amy.
I was wondering, looking back after you understood the cost of some of your care, if there were things or choices you would have made that would have been different related to that understanding?
That's a good question. I think one thing that I didn't know was just how many resources there are out there. I mentioned Fertile Hope as one that covered the cost of fertility. I now sit on the board of an organization called Family Reach Foundation that offers financial support for pediatric families, and they'll actually write checks for rent and for gas and for really practical things. But I didn't know anything about the cancer community or any of the nonprofits that existed. And I'd kind of, someone would mention something to me, or maybe a social worker would say, hey, you should check out X, Y, and Z. But because of that overwhelm factor, it was difficult for me to know how to even begin to tap into some of those resources. And at the time, it didn't, at least to my knowledge, there wasn't a centralized place where, as a patient, you could go and see all of the different organizations and resources that focus specifically on that financial piece and on the practical financials of being in cancer treatment. And I think that's something that would have been helpful at the time.
So I have one final question for you, Suleika.
Yeah.
So in one of your pieces about the cost of care, you said that even though you felt very close to your doctors, you were reluctant to talk about the cost of care with them. And you said, at the point that you wrote this, you said, I've been asking myself why lately, and I'm still not sure of the answer. And have you figured out the answer as to why you are uncomfortable talking about cost of care with your care team?
I think it's, bigger than just healthcare. As a culture, we don't know how to talk about money. We don't know how to talk about what we make for a living. And I think there's also, some gender implications to that. I'm still uncomfortable talking about money. It's something that I've had to actively learn to do. I'm, just from the culture and my parents' culture that I was raised in, you never talk about money. Even, and this is a very American thing, splitting the bill is not something that I grew up doing, because it was just, not something that one did. And so I think that conversation about how we talk about money happens long before you ever get your diagnosis. And I think that there's a tremendous need for more transparency and for a kind of cultural shift that allows for people to talk about money and to talk about things like health insurance and all the other practical expenses that come with being alive and getting sick without shame. I don't know how you do that.
But I think
I'll leave
that's,
that to you
without
guys.
shame, I think is really the, and that's something I hope we're going to talk about some more today. So would you please join me in thanking Suleika Jawad? Whoa. No, that was good.
While I figure out how to turn my mic on.
Is that working? Yeah.
I think so.
So I think that this will be an excellent, really, continuation and a segue into the discussion that we're going to have. This is Tom and Liz Ema. We have a relatively short amount of time to talk about a very complicated story. But I think that's important because when we talk about cost of care conversations, they're not one-off. They're not simple. They don't take place once in the course of an illness and then you move on. I think, as you'll see when you hear their story, these are things, conversations that need to be held repeatedly and issues that come up repeatedly and that they are frequently or maybe always complex. It's seldom a question of making a phone call and getting something settled. So just to give you a little bit of background, I first met the Emas when we did a photo or a video shoot in Hampton, and they volunteered to come in and share their story. And I was struck by how powerful a testament it was about the kinds of issues that people face. People who work hard, who have good faith, who are trying to work within the health system and still run into just barriers and challenges that are really quite formidable. The Emas were living in Colorado, and I'll let them tell you a little bit about it, and moved to Virginia because of Tom's health situation. And Tom, tell us a little bit about what your health situation was at that time.
Well, hello everyone, thanks for having us. But about 20 years, over 20 years ago, I was diagnosed with common variable immunodeficiency, which is a funny name for a rare immune problem. But since that time, I've had to have monthly infusions of gamma globulin, IVIGs, to keep my immune system fortified to stay healthy. But with that, I was also told from my oncologist and hematologist that I had a higher risk of developing lymphoma over time. So for the past 23 years, I've gone into a chemo clinic every month to get these infusions with oncology patients, and I always felt fortunate that I was always able to leave and come back the next month, year after year after year, even though I was living with this cloud over my head that someday I might have cancer. So about 5 years ago, I was first diagnosed with B-cell lymphoma and went through a round of chemo, and then it was supposed to last about 5 years or so. But about 16 months later, I had a recurrence and had the same treatment again. With the first treatment was successful for a short period of time. The second treatment didn't do much. And then I had my spleen taken out as a way to try to keep it at bay, because my spleen had gotten incredibly enlarged. So at this point, I'm in palliative care, and they were kind of running out of options with how to treat me with the protocols that were available. So my mother passed away, and we inherited a little bit of money. So I started to look around and say, well, if I'm not going to, don't have a bright future here in Colorado, maybe I want to come back to where I grew up. So we moved to Williamsburg.
Well, so then when you had good doctors and good insurance in Colorado, and when you came to Virginia, you had to find new insurance and new doctors.
Correct.
And so how did that go?
Not well. Hi, everybody. I'm Liz. Tom actually had 3 rounds of chemo. I know they all kind of blend together. And then the splenectomy, which ended up with several complications, was put in palliative care. And that's kind of when we started rethinking what we wanted to do. We were fortunate enough to move here in 2016. But of course, we moved right when open enrollment was going on. And we're living in Colorado, trying to buy health insurance from Virginia. Virginia doesn't have a state exchange, so I was unfortunate enough to have to go through the national exchange, as everybody else who doesn't have a state exchange. And also, our house wasn't finished being built, so we didn't have an address yet. So that part was very upsetting. Tom's palliative care team back in Denver were VCU grads, and they had recommended the Massey Center, and we were fortunate enough to get in there. So Tom started treatment right away in 2016. I tried to go through the national exchange. I had known back from our time in Denver that we wouldn't qualify for any assistance. So I called VCU myself, gave him the name of Tom's hematologist, oncologist, and asked for all the insurances he accepted. Started calling all of them and went with a big name insurance, called them directly, bought the policy directly from them. So once Tom started seeing his doctor at VCU and getting his monthly infusions, we thought everything was going to be smooth sailing.
And then the bills started coming.
Then the bills started coming in, and we had been on a plan back in Colorado that was medical insurance were all in one. As long as you were in this facility or seeing one of this name physicians, everything was covered. This was the first time of in-network, out-of-network, all these things we had to deal with. But we have been told this doctor was in network. I was told to always check before every appointment to make sure, because they can drop out and they don't always notify you. So I had their app on my phone. I have it on the desktop, and before every appointment, I pull it up and sure enough, he was in network. But after 5 months, we finally started getting bills from VCU. They were horrendous. Many of you, if you've been involved with any type of infusions, they could be anywhere from $8,000 to $12,000 a month. IVIG or gamma globulin, something like gold. It just supply and demand, and it's the only protocol for Tom's immune problem. And he's still dealing with stage 4 B-cell lymphoma at the time, so it was really important to stay on top of the immune situation. So after 5 months, we got this humongous bill from VCU, and I wasn't as alarmed, but Tom was, because I figured if we were just getting the bill from VCU, maybe they now were just billing our insurance, and the two had not met up yet. What?
Okay, so the bills are mounting up, and who did you try to communicate? How did you try to communicate to sort of resolve this issue? Because we're really talking about the conversations here. So
Yes.
What kind of conversations did you try to
Well, if any of you have seen the movie Gaslight, that's very much what it was like. I would call the insurance company, and they would say, well, you're not in network. And I'd say, I'm looking at it right now. Well, you're not in network. And I always say, thank goodness for our millennial son who taught me how to do screenshots. So I started doing screenshots and saving them. And just by way of, I happened to be complaining to a nurse at one of Tom's appointments about this whole thing. They're saying we're not in network. And I wasn't that worried. I mean, it was here on my screen that everything would be okay. And she's the one who recommended Patient Advocate Foundation to us. So that's how we contacted them. And our case manager, Tammy Neese, just told me to put together whatever we could, which were Post-it notes, copies of emails, but we could never get a person, place, or thing with this insurance company to sit down with us and talk with us. We took it upon ourselves to go to Richmond and talk to the billing department at VCU. And again, they didn't even know why we weren't being paid. They were the ones who said, maybe you're not in network. So finally, it was August, so we're probably about 7 months into bills now. I called the insurance company and asked them one more time, and they said, ma'am, that's not even the plan you're on, and gave me a whole new username, put me into a whole new password, and said, this is the plan you're on. And it was all these screens and things I'd never seen before. And interesting enough, what I had been logging on every month to pay our premium was fine. It said our doctor was in network. Now I'm getting one that says he's not in network, and I still can use the other one to pay my premium. So it was crazy making. So we could not get them to meet with us, talk to us. I guess I learned my lesson of never going directly to buy from insurance. Always have a broker, somebody else who has your back. But through our Patient Advocate Foundation, Tammy, Earth Angel that she is, we were able to compile a lot of notes, and Tammy was able, in really short order, because we'd been struggling with this for months, Tom actually stopped treatment.
Let's talk about that a little
Yeah.
bit. So
Sorry.
these bills are piling up. You're not getting any response. Tom, when did you decide to make you're dealing with a very serious illness. When did you decide to make a decision about actually maybe?
Well, a couple little things I wanted to mention too was I was self-employed. I had my own graphic design business for 30 years. So the reason that we have to get our own insurance and we don't have a company policy is I was self-employed and needed it for my employees. And we continued that through the years. But once these bills started coming in, the emotional cost of that was just horrendous. I haven't been able to find the right words to describe it, but the fear was so incredible that it just froze me up. I couldn't open the mail. I couldn't pay bills. I couldn't sleep at night when I'd walk my dog in the evenings. All I could think about. You feel so isolated. You're so alone. There's nobody, all your friends that you've come here to see think you're some rich cat that's bought a townhouse and is retired at earlier than they can, and you're faced with, and these bills were like 40, 60, 80. It was up to like $80,000, and I was thinking, this is going to wipe out my savings. I basically started to feel like I can't afford to live. I can't pay these bills. And so I had and it was like being in the twilight zone because there was no rationale to it. There was no logic to it. We kept trying to recreate what happened or why this could be going on. And we couldn't get any clear information or really understanding of what was going on or how we could resolve it. And I just couldn't, and I didn't want to continue month after month adding, making it 100, making it 120. It was going to wipe us out. And so I decided to stop getting my treatments until, we got some answers. But the downside of that was my cancer flared up, and I had to go back to getting another treatment, and with that, fortunately, we had to switch insurance. Well, I don't know if it's fortunate or not, but after that year, the first insurance company dropped individual plans, which is a whole nother story. We've had 3 different insurance companies since we've been here, because every year the plan that we had was dropped. So we had new insurance, all new doctors. Fortunately, the new oncologists I got did a conference call with our VCU doctor, and he had just learned of a new treatment for my type of cancer, which had been used for leukemia, and now it was approved for lymphoma. And so I got that treatment, and it was covered under the new insurance. And after my 1 year follow-up CT, I was 100% clean. And it's the first time in 20-some years that I've ever had a clean CT. After all, I've had some kind of nodes going on up and down, all around for all those years. So that was a pretty incredible outcome. But
yeah, that's an amazing happy ending to
Very
that
happy
part of the
ending.
story. One of the things we talk about, and we really encourage people to do, we encourage people to talk to their doctors about these issues. We encourage them to become educated self-advocates. And yet, what you're describing is almost the sort of, you can forgive a Kafkaesque type situation where you're just in a sort of, you can't, how do you become a good self-advocate under these circumstances?
It's difficult. I don't have a problem speaking my mind. We get dropped from doctors sometimes, just finding, I don't know, our approach not maybe being as ethical when it was brought up, passive or aggressive or whatever. But Tom's had the same situation of going in to have a biopsy done, and anesthesiologist isn't in network. And I'll say to the surgeon who wants him to have this done, he's had a port put in, those types of things. Well, and they're very cavalier. They're like, I don't even know who's on call that day, let alone, they're in network or not. I've had some orthopedic things done. This is off topic, but it's interesting. My doctor's fee, if I paid it today before the surgery, it's this much. But if I wait 30 days, it's that, this difference in pricing. I've learned a lot of information about medications and, approaching doctors about pay now, pay later, payment plans, all those things. I don't know what to do with it, but I keep accruing it because I've been the one who's doing the insurance and the caregiving. But it was just something that was so black and white to me. And once we had those screenshots, I didn't know how they were going to get around it. Not only were they on the insurance directory, the doctor himself that Tom was seeing at VCU had them listed, had that particular plan listed. So there were 2 areas now. So it really has made a huge difference in just really eyeballing. But as it's been spoken before, when you're that sick, who has the energy? And, it wasn't exactly a fun job as the wife, the caregiver, and the insurance, and as I joke, Tammy, our case manager, got probably some pretty colorful language on the bottom of some of these emails that I'd received, but she said, send them anyway, because I tend to write out thoughts while I'm on perpetual hold with these companies. So it's been quite an experience. And as Tom mentioned, we've been here just a little over 2.5 years, and we've been dropped repeatedly as self-paid, private, individual policies. And we may be, again, we haven't decided
so Tom,
yet.
Just because we're kind of running out of time, but you had mentioned to me when we've talked, and Salika also talked about this, about the cost of these things not simply being money, about the stress and the time, and I think you've both addressed that very well, but do you want to just sort of address?
Yeah, I even include the 20-some years of time I've spent in, chemo lounge chairs and talking to people, kind of reacquainting relationships with people I went to high school with when I moved back to Williamsburg. And, that's part of your life you can't get back. And if it's a choice between life or death, then obviously, yeah, you're gonna put up with that inconvenience. But it does really have an effect on your life and what's important. And in these last couple of years, it seems to have gotten pushed to both extremes for me. Some really scary nights and times, and not knowing what the future was going to be like, and then some real positive, good outcomes have happened too. So it just makes me feel, it just reinforces that life is short and your time is limited, and spend it doing things that you really enjoy and with people you enjoy and people you care about. I was a graphic designer for many years, and now I do oil paintings, and that's what I enjoy doing. And I try to save enough time to do that. But I wanted also to say that I'm a big advocate of the Affordable Care Act, because before they had the policy about pre-existing conditions, we couldn't have left Colorado because I couldn't afford not to have health insurance. I could have been denied for having this pre-existing condition. And then just recently, we found out that we do qualify for financial assistance for next year. So we're very thankful for that as well. And I just hope that we can work towards making it more inclusive, more efficient, and keep improving on the product. But I think I'm glad it wasn't repealed, and I'm glad it's still available, and hopefully we all work to make it better.
Well, thank you. I think your story really illustrates how great the impact of these issues are on individuals, but also how important these conversations are and how broadly systemic they are. That we're talking about not just the people caught in the system, but the whole system. So thank you very much for sharing your story.
Thank you.
Appreciate it.
Here's your mic.
We can get. Now I was going to do the data.
So don't pay any attention to what it looks like in your program. We had quite a little time built in for overflow. Whoop, I'll not touch this. I don't know if I'm ready. Oh, I think we need to turn the mics off. But there we go. I don't think that's me. Okay. So what I'm going to try to do, unlike Suleika, who spoke so methodically and beautifully, I talk in DC, which is really fast. So I'm going to talk fast. You might want to pull a little closer to the viewing field so you can see some of these data. I did my best to make them as big as I could, but there's a lot of data in here. We're going to try to get to a break about 10:35 or so, and we'll come back for the first panel about 10:45, 10:50, and then have lunch, and then we have a speaker during lunch, Peter Ubel, and we'll get into the rest of the day. So when I first started so what I think part of the challenge here is we know how complicated emotionally just the treatment journey is. So then you think about, well, how are you going to infuse the complexity of cost and finances into this conversation, as both our speakers and the caregivers who they represented or who are here to talk with you, they had to take that role on. But the patients themselves are so overwhelmed by what's happening to them emotionally and the treatment they're going through, there's not really room, it seems, to think about and plan for and have these infused costs into the matrix here. The reality of it is we have to do it. It's a reality of the system. As unfortunate as it may be, we have done a really good job of and I don't like this term, but of creating benefit plans that place skin in the game financially for patients. And when I hear people say that, I say, well, patients have always had skin in the game. This idea of indirect costs doesn't exist for patients. Transportation, childcare, lodging, housing, food, those are all costs that come directly out of a patient's pocket, just like the costs that are inside the benefit design do, the premiums, the deductibles, the copays. So that's a distinction without a difference from a patient perspective. There's always been skin in the game, but now we have a lot more cost sharing and cost shifting within the insurance benefit itself, which sort of defeats the purpose of insurance a little bit, in my opinion. But that's the reality of the system we have. So I think because of that reality, we have an obligation to not ignore that reality and not have people trying to deal with that and figure it out along the way, but to actually plan it and infuse it early and often into the conversation so people can be better prepared for it. So that's one of the things we wanted to check, though, because we don't want to just be a group that advocates based on what we think makes sense. We actually go back into our patient population and ask them, what's important to you? Is this an important issue to you? That's the data that I'm going to share with you. We went back, we did this about 2015. We did a survey around financial toxicity. We repeated much of that same survey. We partnered with Avalier had done a survey that they did with Robert Wood Johnson around cost of care conversations. We borrowed some of that and built it into our survey, and then we asked some of our own questions around cost of care as well. And those are the data that I will share with you. Some of you have seen these before, but actually what's new here is previously we compared cancer and HIV/AIDS. What we've done now is actually broken it out by 5 different disease areas. So breast cancer, all other cancers, HIV, hepatitis, and pulmonary conditions. And I think that's important because we tend to think, for some reason, when we think about treatment, especially when we think about the science and innovation we're bringing to the field, is so much about personalization, right? And thinking about subpopulations. But for some reason, when we think about things like quality of life and costs, we tend to take these very universal approaches to things. I give you the EQ5D as an example of trying to take the experience of quality of life and say it's something we can extrapolate and measure across an entire population of patients, irrespective of their disease or their stage in life or their stage in disease. What I want to illustrate for you is I think in every aspect of care, and especially when we're thinking about cost of care, we have to think about how can that be delivered in a way that is at least disease-specific and disease-relevant. And that's just one part of it in terms of thinking about the subpopulation. So that's part of exposing you to some of the differences in the financial toxicity journey, as well as some of the cost of care preferences in those discussions that differ based on disease. And you'll see why in a second. And so I would suggest to you, and I'll sort of steal the punchline here, for some diseases, it's a little less complicated because the financial story is more straightforward, right? So you'll see that. For others, it's very complicated, as we've already illustrated for you here anecdotally through the stories of the patients that I've shared with you, how complicated the cancer story is, for example. And I know there are other diseases that are similarly complicated. So I'm going to run through these. It's like there's mice in the bats in the belfry somewhere. So I'm going to skip. I think most of you know what we do. Thank you. All right, so this is a survey we did. I mentioned it very briefly already in 28. It was a survey of patients that were served by us. I do want to be explicit about that sample bias in the population. These are patients that we served. There was about 1,400, actually for this whole survey, I think we had about, 1,400 total respondents or so. When we pull out this subset, I got to go back. When we pull out this subset of patients, you're looking at about 278 patients with breast cancer, about 300 patients with all other cancers, about 270 patients with HIV/AIDS, about 135 with pulmonary conditions, and about 79 with various forms of hepatitis. We surveyed these patients in 2018 in May. These were patients that were served in 2017. We did things to randomize the sample, et cetera. Don't have time to go into the details about that. I do want to just quickly run through a little bit of the demographics of this population because it is a subpopulation of patients. It's not meant to be a representative sample of patients in the U.S. How many of you feel like you serve the average patient or a representative sample of patient? I don't know why we sort of cling to that idea because we all serve subpopulations of patients to one degree or another. But these are patients that are representative, at least of the patients that we typically do serve, in that they're predominantly low income. They're a mixture of different race and ethnic backgrounds, and to the extent that there's variation in that, it's driven by the disease itself. So, for example, in hepatitis, there is a very low percentage of Caucasian and other ethnic groups. We don't have Asian here, but Asian actually makes up about 40% of that population in this survey. That's because hepatitis B, that 50% of the patients who have that are actually Asian. That was something I didn't know. Many of you probably knew that. Somebody else in my staff was like, oh yeah, didn't you know that? I'm like, no, I didn't know that. So anyway, and then the other interesting thing about the population we serve is they tend to come from small households of one or two, in part because what they're looking to us to be is their case manager, to be the person that's helping them navigate the system, and they don't have that caregiver support, or there's just one or two people trying to figure out this complex system, so we become part of that support system for them. So just a couple of the quick notes. Oh, it's right down here. I don't have to keep looking at things. Most of the HIV/AIDS patients and the hepatitis patients were diagnosed more than 10 years ago. So these are people that are living with the disease. And I know for other diseases, and this is a weird way of saying it, but I think many diseases aspire to be chronically managed in the way that HIV/AIDS and now hepatitis are. For others, the journey is much more uncertain. And that you hope to be able to live with the disease over time instead of dying of it in short order. The majority of the cancer patients, both the breast cancer and all the other cancers, were diagnosed 2 years ago or less. Nearly all of them are still being treated. So that's another thing that's unique about the population that we serve is they're actively being treated. So about 96 to 99% of these patients in this survey are still being treated or have seen a doctor for their primary medical condition in the last 12 months. And nearly all of them are still actively receiving treatment, 80 to 100%. So I think it's important to just ground you, and this is one of the few slides where I'll divide up the different disease categories just because there's such a difference here. And I don't know if you can see this very well, and I can't get too many screens to point at anyway with a pointer. But what types of treatments have you had in the last 12 months? So for cancer patients, you can see the journey is pretty complicated. Now, most of these patients are receiving some sort of drug therapy, about 77, 74%. The breast cancers, for the most part in these slides, the breast cancer is going to be the first blue column and the other cancer is going to be the second red column. But you can see there's a diversity of experiences here. Surgery, radiation therapy, diagnosis, side effect management, preventive medicine, alternative therapies, post-treatment. Now, you contrast that with the HIV/AIDS, the hepatitis, and the pulmonary conditions. You will see that I can go back and forth real quick. You can see everything on the left starts to dip quickly, right? So the treatment experience itself, and this has relevance then to the financial toxicity and the cost pieces, is I'll tie these together. But you'll see that for the most part, the treatment, the intervention world, if you will, for these diseases, at least in our survey population, is mostly around the drug therapy and preventive medication and a little bit post-treatment follow-up. So that's significant when you think about a very complicated, multiple touch points in the system, lots of different things that are happening in the life of these cancer patients, as opposed to these other disease populations who are mostly on drug therapy regimens. That's the benefit of being in a chronic disease management state, as opposed to being, treating with surgery and treating with radiation and treating with drug therapy as well. So that's a setup that actually has relevance throughout this whole series of data. That's why I wanted to just highlight it for you here at the beginning. So then we asked, this is sort of our financial toxicity screening question. It's very straightforward. In the past year, have you experienced a financial hardship to the cost of your medical care? This is the percentage of the patients in this survey who said yes to that question, 80% to a range of 50% for pulmonary conditions. And then we asked them to rate the severity of it. We just use a simple 1 to 10 scale, much like the pain score. And so what most patients, who have said they've had a financial hardship in the past year, most of them rated that between an 8 and a 10 on the highest end of the score. So that was roughly 60%. There wasn't much variation there. Where there is some variation in the data is those who noted it as at the highest point, which is a 10. So what you see there is the percentage of those patients from the sample population who identified their financial hardship that they experienced at the level of a 10. There's a little bit of variation there in the cancer patients reporting it at a little higher than 30% or more, and more in the 20% for the other patients reporting that their financial hardship was at the highest toxicity, if you will. And then we talk about what are the sources. And again, I'm going to, just like I did for the different treatments that these patients have experienced and the different interventions, when you ask, it doesn't no surprise then when you say, what's the source? What's been the cause, the most significant cause of that financial hardship? When you look at the breast cancer and I don't know why the other, obviously both the cancer groups are in here, you can see that it's pretty much everything, right? It's all the different things they identify the source of their financial hardship is coming from, all those different treatments and services they received over the last 12 years. So really, the thing that caused the financial hardship was the last bill you got from whatever the last interaction with the system was. Contrast that with the HIV, AIDS, the pulmonary, and the hepatitis community sample population, and they're identifying most of their costs as coming from the cost of their drugs, and the cost of their lab tests, and the cost of their office visit specialists. So the types of costs and the sources of their financial toxicity are coming from a much more targeted and narrow range of sources as opposed to a disease like cancer, where the sources of cost and the sources of financial stress are coming from a myriad of things. Now, this has implications then if you're thinking about how do you help plan and think about cost, right? Have cost conversations in different disease environments. Some it's a little more straightforward, others it's far more complicated. Yes, so then another way of thinking about this is sort of bucketing these two types of expenses. And I introduced to you this idea of we don't use the term direct and indirect expenses. We think about expenses within the benefit design, copays, deductibles, premiums, and expenses outside the benefit design that are still direct expenses to patients: transportation, lodging, housing, food, childcare, time off work for both the patient and their caregiver. So we asked these cohorts, all right, thinking about these things as buckets, which type of expenses were the greatest source of financial strain to you? Just the insurance-related costs, or was it all the other costs outside the benefit design, or both equally? And not surprisingly, the cancer patients said about 50-50. So it's about 50% the insurance-related costs, and the other 50% was some combination of both equally, which is really interesting, or just the other out-of-pocket costs associated with care. Because of the treatment journey I just described, is probably not surprising then that the other disease populations in this sample picked that the primary source of their financial distress was the out-of-pocket cost related inside the benefit design, which again has implications for the types of cost information that you're going to need to get into those disease communities. I think for some disease populations, you can focus primarily on the more easily knowable things of cost, like the copay, the deductibles, the premiums. For some disease areas, that's not going to be nearly enough because the source of financial distress and the toxicity experience is going far beyond just what's happening within the insurance benefit design. So the other thing to think about here is what's the impact? And Tom alluded to what it ultimately meant for him in terms of his treatment decisions. I think we have to think about this not just in terms of the experience of financial toxicity from its sources, but also what's the actual clinical manifestation, if you will, of that experience. So we focus on adherence, and I think there's this assumption that somehow financial toxicity is inherently leading to lots of lack of adherence in terms of skipping pills, postponing treatment. I think it does get to that point, but actually what most patients report is that as the impact on their medical care is they're just finding other ways to pay for care. They're borrowing from friends, they're dipping into savings, they're putting it on credit cards and loans. And most actually said the other common answer here was that it had no impact. So it was not impacting their treatment, their access to medical care. And I'll tell you why in a second. There's a reason for it, and you heard some of it in the stories that you've already heard from the patients today. But when you get into these questions of adherence, you do have some patients that are about 20% saying that because of their financial hardship, they did not follow their medical advice, they shifted care to a different location, or they stopped or postponed those treatments. But those are actually pretty low levels, 15 to, anywhere from 7 to 12 or 15%. What's more common is just changing the way you pay for care. And if you think about it, if you've got a significant disease, and if not getting to treatment leads to a progression of that disease or some other disease, the trade-off is going to be between, do I pay for things like my house payments, my car payments, my food payments, or do I continue to pay for my medical care? And I think most patients, until they get to a really extreme breaking point, are going to opt to continue to get their medical care because that's a life or death decision for them. So not surprisingly, then when we then ask, well, what was that impact of your financial situation on other aspects of your financial life? And the most common things were things like paying and I should have known this at the beginning. I try to really stay consistent about the y-axis scale here. So everything's always going to be on a scale of 100% or 50%. Be wary of anybody who changes the y-axis scale and starts showing you things like on a 20% scale, because it can over-exaggerate variation between data points. So these are always going to be on a 100% scale or a 50% scale. So here you have on a 50% scale, what's the impact on other aspects of life? And the most common thing is, again, changing the, I gotta go forward, paying utility bills late. And you can start to see there's a difference in these other experiences with the breast cancer and the other cancers, which are the blue and the red, and the other disease areas, HIV, hepatitis, pulmonary conditions. You start to see a little more acuity in these other types of events in the cancer population as opposed to these others. But what's actually more common, at least in the cancer populations, than being not adherent to treatment, is actually paying utility bills late, unable to afford groceries. I don't know if you can. Yeah, it's cut off. I know what these things are. Unable to afford groceries. The second one is you can see missed car payments, attained additional employment, bankruptcy, no or little impact. So there's these cost of life issues, these bare necessity issues that are implicated. I put this in, I don't know why it's rendering so poorly. I was so proud of myself for putting it 16:9 format. So you can't see it, but I'll tell you, you can't see the bottom, but I know what it says. If you had to do, another way of asking the question is, if you had to tell us any of the following things you had to do in the last 12 months, and the one on your left with all the high percentage points of 60, 70% are people that are saying they had to dip into savings or find some other way to pay for care. And that's probably the one key thing that ties these things together. If you're looking for what's a common thing you can look for and ask for a patient, sort of probing about where they might be at starting their progression in the financial toxicity realm, is are they dipping into savings or having to find some other way to pay for care? The second most common thing here is where you see the 30 to 40%. The next group of columns is actually patients that are saying, I chose to not pay another bill so that I could pay for my medical bill. So it's actually, I'm not paying my utility bill, I'm not paying my rent, I'm not paying my mortgage. We think that's actually probably what's happening more frequently, at least in the patient population we serve, and that's why these issues like transportation issues, rent issues, food issues, those are sort of the early progression, the early stages of financial toxicity. And if you don't address it then, right, that those things then spiral out of control, and then you ultimately probably get to a point where patients are deciding, just like Tom alluded to, they're then finally deciding to stop or postpone treatment. But for them, it's probably gotten to a pretty significant position in their financial world where they're having to make that trade-off, as you heard already. So another way of asking, we sort of think of it as they're on the edge of a cliff, right? And that's where things like the financial support and the Hope Lodges and the copay assistance, those things that they're not curative, right? They don't solve the financial problems. Some people have referred to them as dirty band-aids, which I think is a horrible way to think about this, because it really helps patients survive to get to the next day of their treatment. So a lot of these patients are living what we sort of call the edge of the cliff. So here's another question we asked. This is actually a validated question from a completely different area of behavioral research. But in the next 2 months, this was the percentage saying that they pretty much, or a great deal, anticipate having to reduce their standing of living to just the bare necessities of life. So this is the percentage of patients who is on a Likert scale. So the highest percentage was in breast cancer and other cancers. Then you had still a fairly significant percentage of the other disease population saying that they're pretty certain that they're going to be reduced to living the bare necessities in the next 2 months. So now I want to switch gears and talk a little bit about the actual experience around cost of care, and this will be pretty quick and then we'll get into what are some preferences. What are these patients, when you ask them what they prefer? What types of responses do we get? So this is a subset of the population. We wanted to ask those patients, only those patients who had made a medical decision either to start treatment or to change treatment in the last 12 months. So this is the percentage of those populations. About half the cancer population had started treatment or made a decision to change treatment in the last 12 months. Much smaller percentages in the other diseases because they're being, many of these patients have been diagnosed for 10 years, and their disease is being chronically managed by some sort of oral drug. So this is so how much, so there's, it's NQF 2962, I believe, is the standard NQF endorsed measure set for shared decision making. So we wanted to just give you a sense of what that looks like in this population. So these are the first two questions from that measure set: is how much did a doctor or other healthcare provider talk with you about the reasons you wanted to have your treatment you chose? This is actually pretty ceiling. There's a lot of pretty consistent here. 70 to 80% of the patients in our population said this was on a Likert scale, said a lot. So not a lot of ability. There does seem to be a lot of conversation about talking about the reasons you wanted to have treatment. What's less common is, and this is another question with the same scale, is how much did a doctor or other healthcare provider talk to you about the reasons you might not want to have treatment, the treatment you chose? That's at a much lower level, 21%, 24%. This is of those who said a lot. So contrast that with the 80% who had conversations about what treatments they should choose. There's a lot less conversation going around not having treatment at all, which I think is important to consider, because that's obviously one option for patients. They may decide not to have treatment for any number of reasons, or may choose not to have one treatment over another. So here we sort of modeled these cost questions after the shared decision-making format. So these are our own questions that we invented based on the shared decision-making questions. So did any of your doctors or healthcare providers explain the costs associated with the treatment options you discussed? So this was a simple yes or no question. So you can see that for breast cancer and the other cancers, only about 30% said that they had actually had, that the cost was explained to them when considering treatment options. A little bit higher for the HIV, AIDS, and the other areas, but again, I think that's because that conversation is predominantly around the cost of the drug. Whereas for cancer patients, it's a much more complicated environment, and I know that's true of other disease areas as well. Another question we asked was, prior to receiving treatment, and this is of that subpopulations of patients who started treatment or made a treatment change in the last few months, prior to receiving treatment, did you attempt to determine the specific cost you were going to have to pay for the treatment you selected? And again, less so in the cancer and breast cancer and other cancer patient population than the other disease areas, who seem to be more actively pursuing and trying to get access to that information. Again, probably having something to do with the less, I don't want to say it's easy to get access to the drug cost information, the other information around cost for those other disease areas, but it seems like it would be a little more straightforward than understanding the cost and getting all the information you need regarded to cancer costs, as we've heard a little bit of that, the complexity here already. So then another interesting thing was, where did you go to get that information? This isn't we asked later, like, where would you prefer to go? This is just where, for those patients who sought cost information, what was their source? Where did they go to get that information? And most patients are going across the board. Again, this goes breast cancer, other cancers, HIV, AIDS, hepatitis, pulmonary conditions. Most of them are trying to get it from their health plan. They're trying to get it from their doctor, or they're trying to get it from a patient care coordinator or navigator or a patient advocacy organization. But the predominant preference here, at least where patients are getting it now, is mostly from their health plan or from their doctor. Well then, what about the adequacy of that information? So thinking about the medical professionals you've seen in the last 12 months, did you feel like you had all, most, some, only a little, Likert scale here, of the information you needed about costs associated with your care? This is the percentage of these disease populations who said in response to that question that they were able to get most or all of the cost information they needed. And you can see that, despite the fact that it is a pretty complicated environment, about half of these patients across the board felt like they got all or most of the cost information you needed, which I thought was interesting. That still leaves a lot of room for improvement, but at least these patients felt like they were able to get most or all of what they needed. Now, we didn't get a sense of how complicated that was or how reliable that information was, but at least a lot of patients felt like they were able to get to it. So I'm going to leave you with some normative preferences. So, this is more switching from what actually happened to what would you prefer happen? What are your preferences here? So one of the most important questions for us as we embarked upon this is this something you even want to know? So we asked this question: to what extent do you agree or disagree with the following statement? Knowing the cost I'm going to pay out of pocket for my care is important when it comes to making decisions about what treatments I should choose. And we did this on a Likert scale. This is you can see the breakdown here. Around 60 to 70% of patients strongly agree with knowing that cost. And if you add in agree, you're at about 80 to 90% here. So very few patients, at least in the patients we serve, disagree or strongly disagree with this idea of getting access to this information. So we feel very confident in advocating, as complex as it is and as unfair as it may seem, to sort of heap this on top of all the other complexity that patients have to endure in their caregivers in the system. Our patients tell us we want it. We strongly agree, or we agree that this is information we have to have access to. And it's interesting because we asked this exact same question 2 years ago. And I'll highlight that the y-x-axis is flipped here. But you can see about 25% of patients, when we asked that 2 years ago, strongly disagreed or disagreed with this statement. So go back and look here at the little bars on the far right. Almost, you're looking at 1 to 2% disagreeing or strongly disagreeing, as opposed to 2 years ago, about 20 to 25% disagreeing or strongly disagreeing. So even in the last 22 years, there's been a significant movement in demand on the part of patients to get access to this cost information. So another question is how important. So there's two pieces of this puzzle. There's getting access to the information, and then who are you going to talk to about it once you have it? So we asked, how important is it for you to discuss with your medical provider the cost you have to pay for your medical care? And again, this is an issue that all diseases identified as being, at 60 to 80% as being very important, and then another 20%. So add them up together, you're talking about 80 to 90% here, saying it's important that they have this conversation about cost, what they have to pay for their medical care with their medical providers. And then, of course, and I don't have to linger here very long because you already know the answer. When you say what specific types of medical costs do you need information about, not surprisingly, there's a higher demand for cost information as it relates to things like the prescription drug cost in the HIV/AIDS, the pulmonary condition, and the hepatitis population, as opposed to the cancer population, which says we need information about cost across the board. And I broke this up into 2 slides because there's so much data here. But these are the areas where there's the most consensus, where 30 to 40% of patients were saying that we need information about surgery, about laboratory tests, about radiology, about oral drugs, about infused drugs. And then you go down, this is the lesser demand, but still 30, for some of these, 20 to 35% of patients are saying I need cost information about office visits, both to specialists and primary care, about urgent care, about hospital visits. You can see when you get to these other things about loss of income due to inability to work, as well as transportation and travel, it's a little more skewed to the cancer populations than the other disease populations, I think for reasons we've already described. And then another way to think about this is what about, and this is a real choice, this is not sort of this straw person that I'm putting up here for theatrical purposes. We are having real policy discussions about, and real clinical discussions about what types of cost information to put in the hands of patients. And this really come down to, is it the drug cost piece, or is it the total cost of care? And so when we ask our patients to sort of choose between one or the other, which do you think is more important for your treatment decision-making and financial planning needs? Not surprisingly, there's a low proportion of the breast cancer and other cancer patients said that all they want to know is the cost of drugs, as opposed to knowing all the major costs. But even knowing what I showed you, remember back when we asked what's the source of your financial strain, and for the HIV/AIDS, the hepatitis, and the pulmonary conditions, they were identifying drug costs as 60, 70, 80% of their source of financial strain. And the thing they want the information to know most, we actually depict they still 50-50 want either, some split between knowing just the cost of drugs versus knowing the total cost of care. Obviously, for the cancer journey and for other disease populations that are multifaceted in their cost portfolio or landscape, if you will, it's really important to know the total cost of care, not just the one particular aspect of their care. And I'll leave you with I have 2 more slides very quickly here. We told you where patients are going to get their information now, which is health plans and doctors for the most part. We said, all right, well, where would you prefer? to get that, we're not just where would you prefer, we asked what information do you want. This is, who do you want to talk to? If you had a preference, who would you prefer to talk to about costs associated with your treatment? And you can see there's a split here. There's variation in that some of these disease populations would rather talk to their doctor. And again, we didn't unpack this, but I think it might have something to do with, it's a little more simple environment maybe to talk about drug costs and get that information, have that conversation with your doctor, as opposed to all the other things that may go into different disease treatment plans that are more complicated to get your heads around. So it's actually, I know my brother and my dad are doctors. They're happy to know that actually for cancer patients, at least in our population, that's not who they prefer to have this discussion with. They'd rather have it with the patient care coordinator, the patient navigator, the social worker, the billing manager, none of the above, and many are not sure. So I still think we have some room to think about who is the right person to be having that conversation about costs with the patient. I don't think we should assume it should be the doctor, and I think that's a lot to ask of the physician in the normal sort of clinical flow to add this in. I do think there's a role for the physician in the care team, but I think we have to be thoughtful about whose role is it to have this cost, and some of that is different by disease populations, so we have to be mindful of that as well. So the last two slides are really then asking, of the suite of things that you could have at your disposal to try to have these cost conversations, what's the most important to you? So we gave them a Likert scale, and these are the things that patients chose as very important, and we gave them a lot to choose from. But about 60%, this is sort of I'm going to lead with the real winners here in terms of what do patients really want here. But of the things that they say would be very important, and this is pretty consistent, I didn't put the data labels on here because they're pretty there's one place where there's not much variation actually. There's a lot of consistency in this sample population of what they said would be very important to them. It was being provided with a written list of fees, having a savings or some sort of savings or safety net or rainy day fund to be able to tap into, feeling confident that their provider wouldn't give them different type of care based on their ability to afford it, and knowing that the provider is willing to have that conversation with them about cost. So these are things that 60% or so patients said on a scale of 1 to 5 were very important. What I want to leave you with is this. These are the things that were above 60%. And what patients wanted to know, even more than those 4 things I wanted to have, was having access to information about the specific costs that they're going to have to accrue. Not just a list of written fees or sort of general information, but what would be more important is having access to the information that's specific to them and the costs they're going to have to incur, knowing the questions that they need to ask. So just knowing how to have that conversation, what questions to pose, knowing that there may be, and this was the most important one, you can see it hit 80% across the board, knowing what resources and what's going to be there to help them. So I sort of alluded to this in my opening remarks, and I'll come back to it. Of all the slides in here, of all the data questions we asked, this had the highest amount of consistency and the highest rating is what patients want more than anything in terms of knowing the cost and understanding the financial distress. What they want is, what's going to help me with this? It's unfair what would be unfair is to introduce this into the system and really focus on cost and not at the same time have an ability and have a means by which to talk about what are we going to do about it? Just like the neutropenia and the hair loss and those other side effects that patients experience with their care, if we're going to really embrace financial toxicity and cost of care, we also have to figure out not just about how to get that information about cost and have those discussions, but more importantly for patients is, how are you going to help me? What is available to help me navigate that financial distress? Because even if you talk about it and plan for it, I guarantee you most patients are going to run into some sort of roadblock, either temporary or long-term, of financial toxicity, and we're going to have to help them with it in some way. And that's where the resources and the support systems that are available to patients are going to become very important, and I'll leave you with that. So thank you so much. We're going to take a 10-minute break, I'm told. I'm happy to, if anybody wants to talk more about data, I'm happy to stand up here and talk data if you have questions about the data. Sorry I didn't leave you much time for that, but we're now sort of back on schedule, I think. So a 10-minute break, and we'll come back in here for our first panel. Thank you very much.
I wanted to, those were incredible panels, incredible presentations and conversations. And I have to say, I'm still kind of taken back, cut up short about Tom Ema's comment about he decided he couldn't afford to live and that he had to stop treatment because of that. And when we look at when we look at what cost of care and what care people deserve, because all people deserve health care, it's not it is a right. And we think that somebody who had viable treatment options or treatment options and insurance had to make that kind of decision, I can barely speak when I hear conversations like that. Or we heard Suleika say that in order to live, she had to move to New York. But what she also revealed during that conversation was that they didn't move to New York. They didn't have money to move to New York. They were dependent on the kindness of friends and family and a support system that not everybody has. So this is we have two panels today. I think, as we mentioned in the beginning, this panel is about why cost of care conversations are important, and then we have a panel about how to integrate it into patient life flow and clinical workflow. But also, I think what I want to talk about, what I'm hoping we're going to talk about today, and we talked a little bit about our panel prep call, and then some of our subsequent conversations, was not just why cost of care conversations are important, because I don't think anybody disputes that they're important, but to what end are they important? And I think the overall context of this is that they're important to the end of delivering health care and quality health care. They are not just there to check a box in an EHR. Many of us who have gone through the healthcare system feel like we have a lot of boxes checked on a lot of questions that were asked that aren't meaningful. But the conversations have to be meaningful, and the conversations have to be to the end, which is better health outcomes for people who encounter the system, not just why they're important in terms of the business of medicine. So we're really here to talk about why it's important from a patient perspective, why it's important from a caregiver perspective, and both informal caregivers and healthcare providers, and why it's important from a community perspective. So I think the other thing we'd like to do as we talk about in this panel is look at an individual perspective, a family and community perspective, and a population perspective. And we've got the perfect panel to address some of these issues. So I'm going to introduce everybody by name, but their bios are in your books, and I think we have way too much to talk about for me to sit here and read everybody's bio. So immediately to my right is Shirley Bridgette, who is a patient, and we'll talk about, and she's had multiple different experiences both with and without insurance. To her right is Dr. Tammy Taylor. Tammy is a nurse practitioner. Tammy is also Shirley's nurse. And when Tammy is a advocate for National Patient Advocate Foundation, and when I heard her speak and tell stories at our Story Slam, I asked her if she could please come and be on this panel, and she said, "Can I bring a patient?" I said, "Absolutely, please do." So we're thrilled to welcome our friends from Mississippi. And then to Tammy's right is Dr. Jerry Krishnan. Jerry is at the University of Illinois, and coincidentally works with Kim Irwin and some of our other colleagues. And Jerry will talk. He's a practicing physician, but he also focuses on health and population health. And so we're going to ask Jerry to talk a bit about population health. Then on my far right is Dr. Susan Perez. Susan is a health services researcher and one of the investigators on one of the Robert Wood Johnson Foundation research grants. And as we mentioned earlier, there are two streams of grants. One was about reaching underserved populations, and that's what Susan's grant was in, and the other is in the clinical and life flow, and you will hear from Kim Irwin on that. So I wanted to start with a question. I want to go back to, and I'm going to go back to you, Tammy and Shirley, about this notion of the Tom Ema quote, which is still choking me up. But I wanted Susan to ask you to kind of set up this and level set for us what you understand and what you think we mean by cost of care conversations, and what sort of this larger context of what that means.
I think we're at the very beginning of what cost of care conversation means. I think that what we've done is we've established this kind of broad, overarching term, and I think the benefit of that is that everybody can kind of see it as something that they can take part of, ownership, or even it applies to them. So it's everything from out-of-pocket costs to those life costs, such as years lost getting treatment or transportation, and I think it ranges also from patient-provider interactions. Jerry and I had this great conversation of, I think we're at a point in the research where we're all just trying to grasp what is cost conversations, and perhaps it's going to be this overarching area, and within that we'll begin to define the terms and the areas that we need to explore further. We already have the term of out-of-pocket costs, and that's a little niche in itself. We have those, little life costs or transportation costs, and maybe we'll continue to further explore those. But I also think is where we're going to also start to move is what are the ways in which we can begin to measure and explore as we kind of narrow down and continue to come together in these kinds of panels and conversations to further hone in and define and articulate what a cost conversation is. And mainly it's to kind of for those individuals who say, why do we need to even have this, or why should doctors and patients be having cost conversations, or even what is a cost conversation. We as a collective can begin to have one central understanding and definition as we move forward and continue to research this area.
And Tammy, to sort of go back to this idea of what we have cost conversations for, and then also to sort of circle back into what Tamima talked about. You and I talked about that early on when we first met and first talked about the things that your patients face in terms of these trade-offs and in terms of thinking about the present, and also thinking about the present overriding the future. And so if you could talk a little bit, build a little bit upon what Susan said, but also what we talked about in terms of the kinds of things that you see in Mississippi that your patients face every day, and why you think it's so important for you, because you're very active in helping them access resources and talk about cost, and why it's important for you, and why it's important for them.
Okay, well, thank you, first of all, for having me here today. But one of the things that some of you guys have already alluded to earlier today is that oftentimes what we experience in Mississippi is that it's a trade-off. Oftentimes patients, we have a huge problem with non-adherence. We have a huge problem with patients not keeping their appointments. We have a huge problem with people having to decide if they're going to pay their utility bills or pay for whatever other expenses they have besides medical expenses. So we have all of these issues that are going on. We often have people that cannot, even though they have employment, they cannot choose to afford the insurance coverage, because if they do, they pay home. The amount of money they bring home is not enough to pay for their daily expenses like utility, transportation, childcare, all of the things that others talked about earlier today. And what we shared earlier when I spoke with you, I have a patient in Mississippi that was diagnosed with a cardiomyopathy, postpartum cardiomyopathy. Is a mother of three, single parent, works at McDonald's, and chose not to sign up for health care because she could not afford it, and she needed more money to bring home to be able to take care of her family. So those are the type of trade-offs. But if you hear that one story, this happens every day. This is what I'm dealing with every day in clinic. Mississippi did not accept the Medicaid expansion, so that's another huge issue. A lot of patients do not have health care coverage. So can you imagine every day trying to take care of patients that have chronic diseases? And I live in one of the places and work at one of the places where it's one of the sickest places in the world. It's also one of the poorest places in the world. So you can imagine how taxing that is on the mind trying to provide treatment to patients that don't have coverage.
And just to give one follow-up, Shirley, I think Tammy, I was going to go to Shirley next, but one follow-up, we talked about this patient that we talked about, she knew what the, she knew what the consequences were.
Yeah, she did. And the sad thing about it is this patient did not follow up for an entire year because of no insurance coverage. And the patient that I'm speaking of that had the postpartum cardiomyopathy, and what that is anybody that have a weak heart muscle. The general population ejection fraction is the pumping ability of your heart to squeeze anywhere from 50 to 55%. So when we first got introduced to this patient after going through her delivery, her EF was at 25%. So with medical therapy, we was able to increase her ejection fraction to 40%. Why is that important? That is important because anybody EF that falls below 35% is at a high risk for sudden cardiac death. So when this patient delayed medication therapy and delayed follow-up appointments, when we finally got this patient back into the clinic, the patient that we once had, improvement with medical therapy is now back at risk for sudden cardiac death, and she has small children, so you can see the devastation.
And Shirley, we talked a little bit about your story, seeing Tammy in the practice, and from the time you didn't have insurance to the time you did. And if you could just tell us a little bit about that, that would be wonderful.
Yes, I want you to know that I'm glad to be here. I have really enjoyed my visit. But this is my story. It had been maybe 5 years when I first met Dr. Tammy, and I had a follow-up with her. The reason I went to her office was because I had done a test, and the test said that there was something wrong with my heart, and they wanted me to go to a specialist, and that's how I met Dr. Tammy. And in my visit, she said to me that she wanted me to have a stress test. And she told me how much the stress test cost. And I told her I don't have any insurance, and I didn't have the money to pay for the stress test. So that was my first visit, my first encounter with her. And so I left out the office, not getting the stress test, but I still had this that was going on in my heart. And I believe, I don't know exactly, but I believe it was, 5 years later, it seems like? Maybe 4 or 5 years later, I was back in her office, but this time I had insurance. But before that, let me say this, I saw her somewhere, and I told her I have a permanent job with benefits, health benefits. And she says, great, I need you to come see me. Well, I didn't go see her. I waited till my medical doctor sent me back because of the complaints I was having. I wasn't able to do a lot of things without stopping in between. I couldn't complete a task. And sure enough, I went back, and right away I had the stress test done. And right away, everything was done quick, fast, and in a hurry. Right away, I had some other tests done. I was sent to Memphis to have some stents put in my heart. They told me I needed 2 stents. So when I went in for my stents, they ended up putting 4 stents in. And I had one of my arteries was 98% clogged. And, I am grateful that in that time I was kept. I was grateful because I know if I had insurance in the beginning, I just don't believe I would have that blockage like I had. I don't believe I would have that greater blockage. So I give God the praise.
Mm-hmm. Thank you, Shirley. And Jerry, if we sort of go back to this notion of level setting about cost of care conversations, can you give us your perspective as both a treating physician, but also somebody who is a teacher, somebody who thinks about population health, and maybe just the sort of your close-up perspective, but also pulling back the perspective a little bit?
Sure. Again, thank you all for giving me a chance to be with you here today. I think this is a really important conversation that I think most of us are not having. And I think this venue and sort of the people that you have today, hopefully we carry forth what we're talking about today back to where we're coming from. With respect to you, the question you asked, as many of you know, health systems are in a major set of transformations that are happening from a very transactional behavior or fee-for-service to thinking more holistically about the whole care continuum, moving from fee-for-service to a value-based model. Most of us don't know how to do that. We understand that we need to go there, but we are trying to figure that out. One of the areas that we have the least amount of visibility to be able to make those decisions of how to think about the whole care continuum and drive towards improvements in population health is this idea that we don't actually have visibility into the cost of care. It's not like we have all this information and we're not sharing it. This information is fragmented. It's in different places. We don't really know what the validity of some of these data are. And depending on who you are, the costs are probably very different. And there is no mechanism for us to understand not only the costs of us providing care within our health system, which sounds silly, but we don't have a good way of measuring it. Few health systems really know the cost of providing care, if you can believe that. And then we're talking about the costs from the patient perspective, which is obviously not only what's happening in the doctor's office or perhaps in the waiting room or elsewhere, but then also in the home and the lives and how all of this affects people. This is an area that needs better visibility and more ways of understanding what those costs are. The way we see the cost of care, and this is a very indirect measure, are people coming late to appointments, people that are missing appointments. I just had a patient earlier this week that I can't understand why some days her blood pressure is very well controlled, and other visits it's completely out of control. And the biology of a human being doesn't change like that quickly. So we know there's something going on. Likely, probably, she's taking less or more of the medicine that she's prescribed, or perhaps other things that are going on in her life that's affecting her blood pressure control. So we're seeing very sort of distal measures of cost, indirect measures of the cost of care. Probably she's cutting down or substituting, or maybe getting medicines on the internet. These are all the conversations we need to have, but have no idea of how to even start that conversation. So we're seeing it in readmissions, we're seeing it in poor disease control, we're seeing it in missed appointments. Those are probably all costs of care that we have not been thinking about it as a cost of care. The way we've been addressing it at the health system level, I think we need to rethink it. We've been traditionally sending a bill if someone is a no-show. Because we had doctors, nurses, a ready team, and the patient didn't show. There's a cost there to the health system, if you will, but that's probably the wrong idea given what we're talking about today, because what you're doing is adding a stress to a patient who's already obviously under stress. So I would say from a health system standpoint, I know that some health systems are further along in this journey, but most of us are trying to grapple with how do you measure cost, how do you define it, where are the sources of data to actually be able to put it together in a reliable way. And recognizing that everyone's a little different, how do you measure cost at the level of the individual? And what are the systems that we need to put in place to be able to support those individuals? So that's at the health system level. I think, I'm not sure we're at the very beginning of it. We're certainly not at the end of this. We're probably in the middle of the beginning of sort of at least recognizing that this is a problem. And I think this idea of putting a label of cost of care is important. If we can't name it, it's very hard to do something more. So as a practicing physician, I think that when cost of care issues are interfering with patients' lives, it not only is frustrating, I think, to the patient, of course, and family members, but also it adds to the treating burden, because at the point of care, you're trying to imagine, how do I do what's best when the elephant in the room is cost, and I don't have a good idea of what the cost is. And so I think part of this is it's affecting all of us at different points And I think today's conversation and all the discussions we've had so far, I'm hoping we can move forward in a way that allows us to make progress on this.
Thank you, Jerry. And so can I ask you, so one follow-up question, which is for you, and then actually I'd like Tammy to comment on this as well, because you have two very different perspectives of where you deliver care. But is there a recognition that you can't deliver value-based care if you can't integrate a cost of conversation that leads to solutions? I mean, I know you know this, but just as if you look at a larger kind of health system perspective, or what you know of the health system.
I think we're at the beginning of recognizing what the barriers are to value-based care.
Yeah.
I think you've put your finger on it, because I think part of this is we've created models where we have, community health workers going into homes, or we might have a, post-hospital discharge phone call, or all these other tactical things. But most patients either don't want people in their homes or can't answer the phone calls. So these are essentially indicators that our naive approaches of developing and implementing value-based care are incomplete, because we don't understand the full nature of the costs. And by cost, I don't think it's just financial. I think there's emotional costs, there's social costs, there are lost time. And so I think that this is why this is an exciting meeting to me, is that we need to think a little bit better about how do we raise the visibility of the cost of care conversation in the C-suites, where people are thinking about developing models of care that are more value-based. I think it's starting to be there, but I think we have some more to go, more room to go.
Yeah, and I think if you look back at those pictures of Suleika in the video that she showed, which the pictures are heartbreaking. You look at her isolation, you look at her fear, you think about the fact that her mother had to basically give up 2 years of being a mother to be her insurance navigator, and also all of the unknown things that are going to happen in her future. You think about Tom talking about not being able to sleep because he was worried about finances. How can you heal if you can't sleep? It's not possible. And all of the kinds of stresses that he was looking at, and the social isolation as well. So Suleika had a lot of social isolation for many reasons. One of them was being in isolation for 2 months, literally in social isolation. But the other was her age, and Tom had isolation from his friends because of the nature of his disease and the stress that he was dealing with, and the ability to be with people in that stress. Because it is impossible to separate out cost of care from shared decision making. It is absolutely impossible to do that. So I don't know, Tammy, do you have can you build on what Jerry has said and what we've sort of talked about, and talk about it a little bit from a perspective of somebody who's working in Mississippi as opposed to, I know that as opposed to Chicago?
And I don't want to keep repeating the same things over, but I think because we're in the beginning phase, we are going to say things over and over again. But at the end of the day, when I remember going through my curriculum, we did not get trained to talk about cost of care. So I think even going back to the basics, going back into the curriculum and start, preparing providers to talk about cost of care, because oftentimes when clinicians do not talk about cost of care, it's not because we don't believe that it's real, because we understand it, because we ourselves have to go through different care with ourselves and with our families. But you try to separate the two because you want to focus on care. And oftentimes you have to be there's a very thin line there. So you have to be very careful when you're talking to a client about cost of care, because sometimes the patient may feel like, okay, if you're talking about how much the test costs, are you going to still provide me the same type of care if I don't have insurance coverage? So you have to, there's a very thin line there, but at the same time, how do you avoid it? Especially in my situation, you can't avoid it. You have a patient come in the clinic that's been diagnosed with a severe cardiovascular condition, and you have to at some point address the cost of care. Different diagnostic lab tests that they're going to have done in order to try to manage their care in the best way possible. So it's a very, I don't have all the answers. I just day to day try to work with the patients the best way I can. One of the things that we face in Mississippi, we have very, very limited resources. I mean, they are not there. And the resources that was once there, we were talking about last night over dinner, I mean, now you cannot even find those resources for patients that do not have any type of health care coverage. And the problem with clinicians like myself in a very busy private cardiovascular clinic in the Mississippi Delta is that I'm so busy trying to fix problems and doing. Sometimes I don't have the time to stop and say, okay, I need to find this. And I was so grateful to be connected with NPAF to have some other type of resource to try to, figure out what can I do to help the patient. So you have all these different things going on while you're trying to provide the best quality care for patients that when you don't have all the resources available.
So that's a really good transition into one of the other things that we wanted to discuss on this panel, which were some of the cultural taboos, shame, stigma, a sense that you don't talk about money. And I think, and I would love to talk about that from everybody's perspective on this panel, because you all have multiple perspectives about that. And some of the things that I think we also always have to remind ourselves to do is always question our preconceived notions. Mm-hmm. And I think that on the second panel, we're going to talk about some of that and some of the things that we think about in terms of people talking to their physicians about their cost of care and their needs. And I don't know, Susan, can you start and talk about this in a little bit, and especially talk about the work that you were doing, your research work. We'd love to hear some of that as well.
So that absolutely was one of the first things or themes that emerged from our research was, engaging with individuals. One is we started with how would you like to talk to your provider about cost, or how would you like to go about that, and then it came through that I just don't, and we even asked individuals on a scale from 1 to 5, how comfortable are you engaging with your provider about cost? And we observed that healthcare is perceived as very hierarchical. So if a doctor doesn't initiate a conversation about something, the patient will not engage that. The patient's like, I only got 15 minutes. And both patients and providers are saying, we only got 15 minutes. I'm not going to interrupt the doctor. I'm there for medical care. I'm not going to interrupt. I just want to get as much as I can in that 15 minutes. I'm there for medical care. My favorite quote is, my doctor has an MD, not an MBA. The idea of not wanting to question your doctor about cost. It's just the idea of questioning. You were saying something earlier, and it reminded me that the whole about the value-based question is I'm kind of excited about provoking a cost conversation, because I believe that cost conversations do provoke a discussion about value. So when a patient does question cost, I can't, how much does an MRI cost? Or last time I had an MRI, it cost me this much. I can't afford that now. It might provoke the doctor to think, maybe we can hold off. Let's try these other things, maybe something else. And so a lot of it is cultural. So in cultures that do see a very hierarchical approach, so for example, my own culture, Asian culture, and Latino, Hispanic cultures, where there is this hierarchy, that questioning just doesn't happen. We just, at least my family, we just smile and nod and then just leave the room. And then we Google, we're out Googling and asking our family. It's ridiculous, but also very true. I don't know if anybody else does that. So it's individual culture. It's making the most of the provider's time. Yeah. And then there's the whole, like we discussed earlier, the taboo of discussing money and mixing money with medicine and not wanting to receive less than care. In fact, we even brought up the notion of cost screening, or screening for cost sensitivity. Whatever we call it, is just kind of getting a sense of what the patient is able to afford during that day. And even then, I had some participants say, So how would you feel about this? They go, I'd lie on that because I wouldn't want the doctor to give me less than care. In our physician interviews, we took our patient feedback and kind of said, what do you think about this? This is what we're hearing from patients. And it was interesting because they're like, whoa, wow, I didn't know patients wanted to talk about care. I should be more deliberate. Our physicians are saying, yes, I do talk about care, but I don't necessarily, cost of care, but I don't necessarily use the word cost, which is interesting. But I also thought it was interesting that they go, well, if a patient had a problem, I'm always willing to find them a solution. And I don't think patients know that, that the provider has ways. What the doctor and the provider says in that room isn't dogma. Like, that's not the only way to treat you at that moment. And I think we need to also portray or communicate that message. Like, ask or someone needs to at least initiate the conversation. And given the hierarchical nature of how we're seeing a lot of how patients perceive their providers, I'm going to say the onus really falls on the providers to initiate that conversation in some way. And back to the opening question is that, maybe that conversation doesn't actually have to include the word cost because there's so much in that word. But maybe there is another word, and I don't quite have that yet. I think that's far beyond what you asked.
No, but I think that's really important, and it isn't far beyond what I asked, because it is an integral part of care planning. And the other thing that's integral about care planning, which we talk about a lot, is this notion of creating a plan together and co-creating a plan, and that it's a pact and an agreement between the healthcare provider and the patient and their family. And so if you don't have a conversation that's about cost, if you don't have a conversation about what's important to you, which also includes cost, if you don't have a conversation about what you hope the outcomes to be, you don't have a care plan because you only have a care prescription. And a care prescription is very different than a care plan. And a plan, to me, a plan indicates that it is something that we do together. Jerry, I can tell you want to say something.
Yeah, I'm getting, you saw me getting restless here.
Yeah.
I think that,
yes.
I think that part of the challenge as well from the provider perspective or the health system perspective is that we don't know necessarily which one is higher value care. I think there's this, there may be a sense among some people that we know the answer, we're just not talking about it. I think there's a lot more unknowns than knowns, and I'm not going to give the whole quote from Donald Rumsfeld here, but I think the issue is, and maybe to give a little credit to PCORI and to NIH and to RWJ and to others who are saying, okay, if part of what's happening here is we have lack of visibility about which is the higher value care, perhaps we need to do some research to understand between those two options which horse wins the race at the end. It may not just be the drug costs, it could be the side effects, it could be missing work, it could be any number of things that accumulate over time. And in fact, the lower cost approach, lower drug cost approach may not be higher value at the end, or the other way around, where there are, for example, I think we have a general tendency, I think in this country, I was born in another country and I've traveled quite a bit, is that this notion that more costly care is the better care. I don't know. In fact, I think I can recite multiple examples where that's not true.
It's not.
The newest approved drug that is higher cost is not necessarily any better than one that's been on the shelf that's generic. And so part of the issue is how do we start to do some comparative evaluations that could help the clinicians maybe have the conversations with the patients. And I think there are a number of organizations represented here that are starting to peel that onion, and I think that's important.
So I think that also, the other thing that's important about this is it just, once again, reminds us to always question received wisdom, because there is that sense. But there's also the sense that people have that Americans think that that cost is correlated with value, but in fact there's a public agenda survey that was published called Still Searching, that was a project of, I think, New York State Health Foundation and RWJF, and done by David Schliefer and colleagues, saying that Americans actually didn't automatically correlate higher cost with value, but we think they do. So in some ways they might, but in some ways they may correlate new with higher value, but they may not correlate more money with higher value. So I think it's worth digging down into that. And I will say, I will reveal a not particularly flattering to me story about myself recently. I'm a 3-time cancer survivor, and I went in to meet the surgeon I had endometrial cancer, so I went in to meet the GYN oncologist, and he said to me, "Can you imagine? I have these patients that don't want the newest, most highly, the newest technology in their surgery, and I can't believe that they want the old-fashioned big open surgery." And I'm sort of like agreeing with him, thinking, and then when I walked out of that room, I'm thinking, but wait a minute, is new better? Why in the world would I take his side and judge these other patients? But it's sort of a knee-jerk reaction, which is new is better, the shiny object is better, what we've just discovered is better. And I think people don't always question that. And I actually, this was 6 months ago, and it's still bothering me. So Shirley, so one of the things that Suleika talked about, that we talked about at the very end, was that she is uncomfortable. I mean, some of it she talked about is cultural, but uncomfortable talking about her healthcare providers, with her healthcare providers about money and about cost of care, and she still doesn't know why. So how do you feel about talking with your healthcare providers, aside from Dr. Tammy, who seems like she's open, she can be talked to very easily, about care, and about cost, and if you do, why, and if you don't, do you know why?
As a patient, I would want my doctor to talk to me about cost. Now, I haven't always been there, but I would rather be shamed in my doctor's office where it's just he and I, or she and I, rather than get to the pharmacy where they've written me a prescription and they tell me it's $100 and I can't afford it. And then I got to tell the pharmacy, I can't get that, I don't have that kind of money. And so then he tells me, well, you have to call your provider. And so I've learned over the years that there's no shame in my game, because it's going to work for me. So whatever is better for me, I don't have a problem with doing it. So now when I'm in the doctor's office, I ask, when they finish talking, I ask, well, what is the cost? Don't write me no expensive prescription because I can't afford it. I tell them. And so I understand if someone is ashamed to talk to about their finances, because I was once there. Okay. But once you go to the pharmacy enough and they tell you how much that prescription costs, and you stand there and say, I don't have that money, you'll learn to, okay, there's no shame in my game.
And I think, that also brings up a really important point, is that the idea that in this culture, if you don't have money, it's shameful, and that that's the perspective that you're starting from, is this notion of shame. And we have to change that. So if you were to give other patients, because I think it sounds like you've gotten this, as you said, there's no shame in your game. You've gotten over this. You understand, but you started with shame.
Yes.
So
yes.
How would you counsel? I know that you're also working on you do some education around cardiovascular disease in your community. We talked about that.
Yeah.
So could you talk a little bit about the education you do, and also how you would counsel other patients to think about, to get to the point where they aren't ashamed to talk about money and they don't see it as something that's shameful?
Well, Dr. Tammy and I have started doing once a year a heart awareness gathering in the community where I live, and it's been successful, and I'm looking forward to grow even more, because after my incident I took this on, that she encouraged me to do this. And I took it on. And so inside of that gathering, we talk about being aware of your physical and not being ashamed of even how you're feeling and going to the doctor, and even the fact that you may have little money or no money at all. But let's make sure that you can say what you need to say. Well, I teach that anyway, about saying how you feel. You know, you got to speak your heart. What is in your heart? What are you feeling? Because I've learned over the years that when I go to the doctor, I have to tell them what's bothering me so they can give a diagnosis. But if I don't speak up, then they probably will give me the wrong diagnosis, the wrong medication. So we tell them and teach them to speak up. Mm-hmm. Speak up. Say what you want to say. Don't be intimidated because they are your doctor. Just open your mouth and say what you're feeling. So that's one of the things that we talk about inside of our gathering that we have once a month in February.
And how do people respond to that?
They respond. You know, they okay with it. They trust us with it. They believe, and I even do follow-ups. Mm-hmm. If I know someone going to the doctor, I ask him, what did the doctor say? What did you say? How did you handle it? What was your response? And sometimes it's good, and sometimes, well, I didn't say anything. And I say, okay, well, you should have said this, and you should have said that. And so we follow up with them and keep up with them. I have had to actually take patients to the doctor, and I go in the doctor's room with them because I'll be their mouthpiece,
right?
You know?
Right. Right. So Tammy, from your perspective on the provider side,
well, one of the things we did talk about, because I love this quote: people don't care about how much you know until they know you care. And for some reasons, my patients tell me sometimes more information than I would care to have. I'm like, okay, but I think they feel comfortable with me, you know. And like Susan said, you have to open up the conversation, because you have to ask yourself, how comfortable are you with money, with discussing money? It's like anything. It's like, I'll compare this, and I know this is different, but when my male patients come in and they believe their blood pressure medicine is going to affect their libido, right? Mm-hmm. So they'll stop taking their blood pressure medicine. And I tell them, I say, I'm going to put you on this medication. I said, should it affect your libido, your sex drive, I want you to call me, and I want you to stop your medicine. But when I open up that conversation with them, guess what? They call me. So it's the same thing with money. It's the same thing. You got to ask yourself, how comfortable are you with money? And I want to go back to something that Jerry said about newer drugs. Mm-hmm. I, again, will echo that I live in one of the poorest and one of the sickest areas, and I treat some of the sickest patients. And we cannot give everybody brand name drugs. But I can assure you that we have some of the patients with EFs, and you guys will get this ejection fraction, heart muscle. This is how your heart squeezes, how it pumps. We have patients that are walking around in Mississippi with an EF of 5% on generic medications. And this is not one patient. So, and it's not on the best. Newer drugs is not always better. The problem that you have to understand with patients is like what he said earlier. If patients are skipping medication, and I see that a lot. You know, you get a patient come in and a month ago and the blood pressure was gold, 120 over 80. Great, good blood pressure. And then you see them come back and nothing has changed, and their blood pressure is 190 over 82, and you're like, what's going on here? Have anything changed? Did you stop your medication? So newer is not better, but it's what it is. It's adherence, consistency, things such as that. So I'm glad you brought that up, because it's so true, because it's what we deal with every day.
So just to make a slight transition, a slight segue, which I hope will bring some of this together, and then we're going to open up to questions from the audience. We looked at, there were two surveys that were presented. The Public Agenda survey that said that 70% of Americans want to have cost of care conversations with their providers, and only 28% report doing so. and that was something that was published in by Public Affairs, but also cited in a new blog in Health Affairs. And then our PAF data say that 74% of cancer patients and 78% of HIV patients agreed or strongly agreed that knowing about their cost of care influences the treatment decisions, is important in making their treatment decisions. So if we think about those two things together, which is that there is an incredible desire to have these conversations, but that not only is there a desire to know because of how much it's going to affect you financially, but also because of how it's going to affect outcomes and decisions and this care planning together. I'd like to hear your perspectives from the various places that you work, that you interact and your communities. How you think that we can achieve. Maybe we can get up to 50% if we could, of having those conversations. And how do we also tie cost conversations to choice and to outcomes?
I think we need to start with what I call normalizing the cost conversation. I think cost conversations aren't with just individuals who you see are on public insurance. I really believe that it's also the individuals who are high deductible plans. Like Tom was mentioning, oh yeah, everybody thinks I'm retired early and I'm living on the high, but really you're struggling with medical costs. And so as we're seeing high deductible plans become more and more prevalent, the individuals who you assume might not be struggling with costs might very well be paying the most out-of-pocket costs. At the same time, I think when you normalize it across all individuals, the individuals who may often feel singled out or stigmatized as having that cost conversation, you can actually sincerely say as a provider, this is a conversation I have with everybody. So I think that's one way to approach this. I'm so sorry, I forgot the question. What was?
Well, I think the other side of this is how, by normalizing these conversations, how do you impact outcomes? So to take your normalizing, take that further. How do we impact outcomes? So they're not just cost conversations that are for the sake of talking about cost and your bank account, but they're talking about your sort of health account and what you're doing with your health.
Yeah, I mean, and absolutely, I think it all falls back onto the whole continuity of care and ability to access it. At the end of the day, if people can't afford their health care, if you don't have these cost conversations, you're not communicating with your healthcare provider. And if you're not communicating with your healthcare provider, then there's clearly a breakdown in trust, communication, and then the patient just kind of, their health falls to the wayside, and you end up finding out in ways of high blood pressure, showing up at the emergency department. I mean, it's a side effect. It's clear the outcomes become medical when they can't afford their care. At least that's what I've heard and observed.
Yeah, and I know one of the quotes from your work is that somebody asked one of the physicians, "What's the side effect of this treatment?" and they said cost.
Yeah, yeah. One of our physicians
said cost.
Yes.
So I love that you brought up this notion of trust and how trust is broken down when you can't have conversations about cost, and when you can't make decisions around cost, and can't and there is not a caring relationship then. Tammy, do you have anything to add to that, to what Susan said, and thinking about trust and trust with your patients?
Well, I feel like I have to go back to Miss Bridget and I, because she's here and she can speak on that behalf. It's very important, especially in rural areas, when we were talking earlier about when Salika talked about the clinical trials.
Right.
And we all are very much aware of the Tuskegee syphilis trial many years ago. But if the trust is not there, the patients are going to have a problem discussing cost of care. And how does that impact outcome is that if the patient is having problems discussing with their providers the cost of their medication, like Ms. Bridget, and then when they get the prescription from the provider and they go to their pharmacy and they can't afford the drug, a lot of patients don't let their providers know that they can't afford the drugs. They just don't get it.
Right.
So then you have the other problem you have with patients. We have a lot of heart failure patients that are being readmitted to the hospital, sooner because they can't get the medication. So it's very important because it impacts the whole dynamics of everything. So that's what I would have to say.
Jerry?
I think that I don't think we're going to get to value of care until we get our arms around cost. Mm-hmm. It's almost too obvious to even say it that way, but the whole discussion has been about value.
Right.
And I think today's meeting certainly has helped me, crystallize even more importantly the importance of understanding costs, recognizing for some specific patients or conditions we may have a better sense of costs, but even then I would say we may understand the cost from the health care standpoint. We have relatively little visibility at any scale on the total cost at the patient level. So I think number one, we need to acknowledge it, and we need better information about what are the total costs of care for different types of individuals. We need to recognize those costs of care are going to vary tremendously for the same condition depending on the circumstances of that individual. So we need to think more broadly than the average cost. The average, I think very few people are average. The other point might be that we may also, with whatever information we currently have, develop tools to facilitate that conversation. I think I certainly was never trained in discussing costs to patients. I'm now in C-suites where cost is constantly discussed, but it's not in a way that's transferable to the patient.
Right.
So I think we may need decision tools or communication tools or some supports to facilitate that conversation, because I'm not sure everyone is as facile in having those discussions. So I think that those are the two areas. One is to acknowledge that understanding costs are critical to delivering value. I think everyone recognizes we need to go there, so we need better data. But second is maybe developing and testing tools to promote a more effective communication.
And I think the other thing, just to reinforce that, is that most of the value discussions have come from a lot of them come from an economic model. They don't come from a humanistic model, and many of them are focused on what is going to be paid for and not paid for by the system, not what the value is and the cost and cost considerations are for patients, families, and communities. So I think we have to flip this conversation and really flip this value conversation and the cost conversation around value. So Shirley, I'm going to give you the last comment on this section of the panel, and then I'm going to open it up to questions.
Well, let me say this. I have learned a lot since I've been here in this session, and I'm looking forward to share it with my co-workers, my friends, my members, and at my church. So I'm willing to carry what I've heard and learned back to the Delta. I trust and I understand and believe with all my heart that there has to be a relationship between the patient and the doctor. If there's no relationship, I don't believe that the patient is going to be honest. I don't believe that the patient is going to open up and actually say all that's going on with them. And same way with the doctor. Sometimes you can go in the doctor's office and they be so rushed, and you clam up because they don't act as if they have time for you. Or you can go in and they can make you feel comfortable. They can make you, relax, and then you begin to talk. It's that, and that's what a patient likes. They like to know that a person cares about them, and that's what I've found with Dr. Tammy. And one instance that I can share was that they are so busy. Sometimes I have to wait for a long time, And by the time you get in the room, you are so aggravated. You are so aggravated. Then you get in the room and you sit there for a minute or two longer than you want to.
In that gown and you're freezing, yes.
And she come in the room and she say, "How you doing?" "Oh, that's on now." She asked me how I'm doing. And she has a way of just calming you down and explaining to you about things that have been going on. And then you begin talking about why you're there. And so, but if you don't have that, you won't build that trust. You won't build that relationship. So it's a two-way stream, from the patient to the doctor, from the doctor to the patient.
Great, thank you. Very well said. Mm-hmm. So I'd like to open this up to some audience questions. We've got about 10 minutes for questions. Mary. We're handing you a mic.
Oh, I'm loud, but okay. Okay, I'm louder with the mic. Okay. The idea of talking about value and cost versus value versus cost. And I think one of the concerns that patients have, and I had a conversation recently with someone about this, and we'll talk about it in the next panel, but their reluctance to talk about anything other than their health care and their health status because of the concern that the value that they receive thereafter will be based on what the perception is of the cost. And how do we get over that? I know part of that does have to do with trust. I think that's a major issue. But the other issue is simply, since we're saying that we have to have these conversations, and we do, there's a reason for them. And so in my head, if I don't understand particularly if I don't trust the system anyway, and if I'm low income and I don't have good health care and so on, is, okay, once I tell you I can't afford it, what are you going to do other than give me something that's cheaper? And that really is a perception that some patients have. And how do we get around this when we're building the system so that we always have this conversation?
So I did a number of physician interviews, again, matching. So I did a number of patient interviews, and then I did a number of physician interviews, and I basically took those patient findings and said, is this what you're experiencing, to the physicians? And it's interesting because I said, patients don't have these conversations for the reasons that you had mentioned. And one is they always say, I typically, when a patient can't afford something, whether it's a patient came back from the pharmacy, whether they came back, their return visit and nothing's improved, and then they have to reveal that they couldn't afford any of their medications, that the provider says, I always have an alternative. There's always a plan. And whether it's interesting. It's like changing the dose from 50 to 100 will totally alter whether it's covered or mail order versus going to the pharmacy. These little tricks of the trade that the providers can do to help it then become covered or even more affordable. I had a lot of examples of providers going to Canada. Interestingly enough, they know the cost of prescriptions in Canada, but not in the United States. But one of my most interesting and favorite anecdotes was a provider who goes, if this provider knew they were handing an expensive prescription, they would start the conversation with, this is typically it's really expensive. Should it bounce back? This is our plan. Or I've had this experience before, go try it, because I'm not sure how much it's going to cost you. But in the past, what we can do is we can work with the pharmaceutical company. I can have my nurse do this, X, Y, Z. I've done that before. And so it kind of says there is a plan in place. I've done it before. It's successful, but it initiates that. It doesn't necessarily just leave the patient out there hanging, thinking I'm the only person with this problem. It kind of puts a plan, and to me, that's a cost conversation. It's handing a prescription saying, this might be expensive, but I got a plan for you. Just try it out, and we'll go to plan B. And so that is something that I observed has been incredibly successful, and that is in the realm of providers don't know the cost. These providers don't know the cost, but there is a conversation, and there is still a course of action that they are taking. not knowing cost.
So does anybody in this panel, or Susan, do you know how often that conversation is opened up? I mean, I think this is, you know, we talk about these ideals, but I think from a patient perspective, and maybe Shirley can talk about this as well, I'm not sure that conversation is invited very often. That may be a conversation the physician is having in their head. Is it coming out of, or the healthcare provider, the nurse practitioner is having in her head, but that may not be coming out of their mouths in their conversations with their patients. They may just give them a prescription and not think that, I always have an alternative, but the patient may have no idea they always have an alternative.
So that came out of 1 out of 20 participants, and I think that perhaps came because this physician actually knew it was a very expensive medication. We're writing a paper right now, it's under review, and one of our comments is, this is biased because it is physician reported, right? They tend to overthink that they are having them more. So you're absolutely right. They're not having them that often, but what it gave me was there are tools and processes that can, and conversations that can happen. And I felt like that was one way in which we can engage providers who are making decisions and trying to have cost conversations and avoid of cost. Mm-hmm. Like that is a way in which you can engage and have that conversation. Yeah.
Yes, Helen. Right behind you.
Helen Bergstrom from the Council of Medical Specialty Societies. It's been a great discussion. One thing I think that's often left out of these discussions is how important it is for clinicians to have the information they need at the time they need it. Right. It's really hard. I mean, as much as there's not transparency for patients, the transparency for physicians and other clinicians as to what things cost depending on your health plan is pretty opaque. So I think putting the right tools at the right time in front of clinicians is an important piece of this puzzle, without which we really can't answer it. And April made an interesting comment earlier on Twitter about, in many ways, this is a really important part of screening, but unless you have the ability to actually do something about a positive screen here, patients have financial issues, it's really hard to know what to do. So again, let's just not forget the side of, I think clinicians want to do the right thing, and I think if you put the right tools in front of them at the right time, I think they'd be more open to these discussions.
And that is absolutely the perfect transition to what we are going to be talking about on the second panel, which April Barber is on, and Mary is moderating, and Kim Irwin is on. Kim will talk about some of their experiences at UIC and Mount Sinai in terms of these conversations. Amy Matthews will talk about some of the healthcare delivery. Amy Russell, Rita Matthews, I'm getting my names mixed up, excuse me. We'll talk about some of the decisions, some of the experiences that people have had. I would like to ask everybody to join me in thanking this phenomenal panel with extremely thought-provoking, insightful, and very diverse points of view. So thank you so much.
Thank you.
We are going to take about 10 minutes to go get our lunch and come back, at which time we're going to have a special luncheon discussion on pseudoscience by Peter Hubel, who he was a self-described pseudoscientist, behavioral scientist, but we will have a lunchtime discussion.
You can eat and listen, I hope. It's our great pleasure to introduce Dr. Peter Hubel, who is going to be speaking to us about cost of care and about behavioral science. And we are very pleased to, he's from Duke. We're very pleased to have him here, and he is our guest luncheon speaker. So thank you, Peter.
Pull up slides here. Yep, I do. Awesome. All right, just chew quietly. That's all I ask, and stay awake. But that's my job, is to make you want to stay awake. So you had one sentence to try to empower patients with some kind of health policy. Tell these people down the road some policy, policy you'd want to empower patients. What would it be? Just somebody, I'll take 3 examples from the audience. Yes. Make the system less complicated. Great. basic level of coverage. Is that what you meant? Coverage of care. Yep. And the third and final, transparency of everything. The physician's clothing, everything. Yeah, I don't want to think about that. Okay. So a few years ago, Tom Price wrote the Empowering Patients First Act. Paul Ryan wrote the Patient's Choice Act. So the language, the title of the bills suggested patient empowerment. The way that both of them were going to empower patients was largely to promote more, the euphemism I think is the consumer-directed health plans. How about high deductible, high out-of-pocket health plans? And so one of the things going on in patient empowerment land is the idea that when people face high out-of-pocket costs for their health care, they are empowered as consumers to scrutinize the cost and quality of care. I'm not going to spend a whole lot of time shattering that myth because we've talked a lot about it already today. It's not empowering to face out-of-pocket costs that you can't determine in time to inform your medical decisions. It's certainly not empowering to face costs you can't afford for care you ought to receive. And so I won't dwell on those. Instead, what I want to talk about is how, even though they never passed those bills down the road, this is what's been happening in the United States anyway. 25% of employers right now only offer high deductible health plans to their employees. And based on a recent survey, another quarter of employers are thinking of moving in that direction. So without Washington making this happen, it's happening. And it makes it all that much more important for us to talk about out-of-pocket expenses with patients to help them inform their medical decisions and help them find assistance, financial assistance in time if they need it, et cetera. So because out-of-pocket costs are burdensome and sometimes they're unnecessary, sometimes they're avoidable, and we haven't talked about them in time to deal with that. So what I'm going to do in this talk real quickly is just say why I think clinicians need to talk about these costs with patients, the way they would discuss any treatment side effect. And I'm going to look about how we actually are talking about those costs now, and you'll see, I think we can improve that. And I'm going to leave lots of time, I think, for some Q&A. Or for you to opine with me and tell me what I got wrong, which is totally cool. So actually, thanks to the help of Robert Wood Johnson Foundation, I was able to study out-of-pocket cost conversations a few years ago with worked really closely with a medical student at Duke at the time, Wynn Hunter. He's going to be a cardiologist soon. Fantastic guy. And we partnered with a company called Verilog, which I have no financial stake in. They've never paid me, but they gave me access to their data, so I'm grateful for that. They audio record clinician-patient conversations in order to do market research, always with the permission, of course, of patients and clinicians. They transcribe it and de-identify it, and they gave us access to a lot of conversations where they were being audio recorded just because they came in to see their doctor to follow up care for breast cancer or rheumatoid arthritis. There was no explicit agenda about cost of care. We then later scooped up those conversations to see if people talk about costs, and if so, what they talk about. And we looked at 3 categories of patients: women with breast cancer coming back to their oncologist, patients with rheumatoid arthritis coming back to their rheumatologist, and people with a history of severe depression seeing their psychiatrist. So most of these were follow-up visits, and these are all patients who face high out-of-pocket costs, which is almost true of every patient these days with any kind of chronic condition. I won't bore you with some of these pseudoscience methodologies, as we talked about. But they had this database where we could just look for words that occurred anywhere in the conversation. Like the word insurance came up or the word expense had come up. We could look at that snippet of conversation, see if it was about healthcare costs, and now we can look bigger at that conversation and find out what's going on. So this is a way that we identified conversations, and we found out how often people talked about cost. I'm going to back up for a second. Oh, I can't back up from this, can I? Yes, I can. Before we did this study, if you looked at the literature, which occasionally I do when I have nothing better, you found patients saying they rarely talked about costs with their doctors, doctors saying they rarely talked about costs with their patients. And I think partly that was because they were wondering about maybe really long conversations about specific costs. But when it comes to just talking about costs in even mundane and important ways, we found rather than 25% of patients ever talking about costs with patients, we found 20 to 30% of the actual single appointments had some cost conversation in it. Among women with breast cancer, about 20% of the time, costs came up during the encounter. The red part here is where all they did was talk about insurance coverage, like, well, doc, is that covered by my insurance? Yes, it is. That might be as long as the conversation is. The blue is actually went into a little more detail, like, what are my copays, or what, right? In depression, rheumatoid arthritis, you saw even higher rates of cost conversation. And actually, interestingly, in psychiatry visits where they had the highest rate of cost conversations, they often came up when the psychiatrist was kind of going through an inventory of life stressors, which if someone's got major depression, you want to understand, how's things going at work? How are things going with your relationship? How are things going with your kids? How are things going with you financially? And they'd ask a general financial question, then the patient would say, well, great, except I have to pay every time I come to see you, or, gee, that medicine you gave me was pretty darn expensive. And so that you saw more cost conversations during psychiatry visits because doctors routinely asked about money. Gee, that's a great way to get a conversation started, talk about something. Now, I won't go into too much depth on the details, except to say that what it means to have a cost conversation, there may be different ways of defining it, and I just want to say we could be really, really strict here. It has to be specifically, explicitly about a patient's out-of-pocket costs. I can make it a little more generous and say, or insurance coverage, or I can be really generous and say any, like talking about how expensive their kids' medical care is would still count as cost. And what you find is, of course, the more generous the definition, the more common the conversations are. But even when you're really strict, you're talking about 30% of the psychiatry visits still had cost conversation going on. So you can be pretty nitpicky about what you count it. So I mean, 10, 15 years ago, I'd be talking to colleagues about the importance of these conversations. I was trying to do research on the topic, and everyone was like, that's insane. We shouldn't be having these conversations. We're having these conversations. So now the question is, how can we have better conversations? Who started these cost conversations? It turns out it was physicians the majority of the time, and almost always when physicians started cost conversations, it was either to assure the patient that something was covered or to ask them whether they knew whether something was covered, or explain that they weren't sure if it was covered, and before they finished the order, they would check on coverage. So it was almost always about insurance coverage. For patients, when they started cost conversations, quite often it was to complain about a cost they'd already incurred that they didn't know they were going to incur, and letting the doc know how burdensome that was, and then they would try to problem solve. And again, the little colors and the details aren't as important as knowing that when costs come up, if you look at the height of the bar, about 40 to 50% of the time, if cost conversations began, there was at least one strategy that the doctors or patients talked about to reduce out-of-pocket costs. So it's not like they just mentioned cost, complained about them, and went on. You know, almost half the time, there'd be some discussion of, okay, well then how can we get something cheaper or better or a lot more efficiently, et cetera. So we're having a lot of cost conversations, and a lot of them are beginning to be productive. And in fact, here's some of the strategies people talk about to reduce cost of care. And this is in a system, as we've already talked about today, where prices are often opaque, purposefully opaque, where there's no single price for anything. It depends on what insurance coverage has. And even if everyone had the same insurance plan, it would depend on how far they are through their deductible and their out-of-pocket max of the year. So there's never going to be a single price in our system, or not anytime soon. So it's opaque and inscrutable, right? Yet, you're still seeing productive conversations. It can be that you change someone's medicine. You could come into the office to get an infusion treatment that will be covered under Part A of your insurance, rather than if we give you an injectable at home that's covered under your medication coverage, which is less generous. So you saw doctors and patients just kind of figuring out what would work best given their coverage. You'd see people changing from one type of therapy to another when they realized there were different out-of-pocket implications. And then you'd see them talking about whether they're trading much off for quality of care, and that could get uncomfortable at times. Here's an example of this doctor. Do you need anything else? A Nexium, that's expensive though. How much is that? $150. Well, why don't you ask the pharmacist which medicine is the least expensive and have him call me? I don't know why it would be a him, but you know. But again, here what you're seeing is a clinician saying, I don't know the answer to what your costs are going to be, but we don't have to know at this moment. I'm just letting you know. I'll help you find, well, you know, let me know what's affordable, and that's what I'll prescribe. Pretty simple solution. There are better ones we should build into the system, but that's a pretty simple one. Not surprisingly, switching from a brand name drug to a generic was one way to save money. And when I practiced in the VA, I had a number of people who would come to see me, not because of my fame, trust me, but because they had private coverage on the outside and they could no longer afford their medicines. They'd come in to see me, and of course I'd look at their list of medicines and I'd see them on 4 or 5 brand name drugs where there were generics available, and saying, I'm happy to see you, but you're driving an hour to come to me. Why don't you go back to your doc, and I'm going to write down some suggestions for the medicines. Go talk to your own physician, see if they're willing to help find less expensive medicines before you start coming here to see me. Changing the dosage or frequency is like following up women with breast cancer and deciding maybe we can get a PET scans annually rather than every 6 months, and just follow with a CT scan in the 6-month interval in between, which has lower out-of-pocket costs for this particular patient. Spacing out how often you see your psychotherapist. Now, this can be really bad if people need more frequent PET scans or psychotherapy visits. These are the trade-offs that people are struggling to make at times, but if you don't talk about it, you can't find out how patients want to make that trade-off. Last time I was here, we're going to go with 40 milligrams of OxyContin. We were going to do it 3 times a day, but that's not going to work for me. Well, what's going to work for you? I mean, the tone of voice, you don't read it. I think this was a really empathetic. Okay, then what's going to work for you? No. Well, I have to spend $200 on pain medicine. That's how much these pills cost. I'd rather just go back to the 80s. So they actually just switched the dose to where they could, whatever there was. So this was a really common thing. The patients were proposing strategies at least as often as the doctors, because they ended up knowing the details of their own out-of-pocket costs better. And so once you start the conversation with your patients, if you're hesitant to have a conversation because you don't know how you're going to solve their problems, you've just lost, talking to the person who probably has the best insights into how to solve the problem sometimes. Then you can just stop certain trajectories of care. Do you want the tramadol, or we could take it as needed for pain? Well, I could try it. I don't know. We could try 60 of them at generic, so hopefully the cost wouldn't be bad. If it was bad, just say, no, I'll skip it. It's not ideal. I'd like to see another alternative if it's too expensive. But an alternative is to say no to things if they're too expensive. And now those are times where the lower cost, you lower the cost by changing trajectory of care. Sometimes you'd keep them with the same line of care, but you'd just find a way to make that more affordable. You can say a less expensive pharmacy. I should not have the word cheaper there. 90-day supply versus 30 days if they have the same copay no matter what. There were times where the patient said, why don't you get that scan for me in December? I've already reached my out-of-pocket maximum this year, and if you have it in January, all on me. And so, voila. For this medicine, the one doctor said it's cheaper to buy it directly from the company rather than the pharmacy. The company won't mark it up, or mark it up, yeah. Facilitating copay assistance was a major thing. You saw that a lot in the rheumatology interactions, where there are a lot of really great and really expensive medicines, and the rheumatologists deal with those medicines so often, and they deal with patient complaints about the cost, that they've kind of got it down, to, at least if they have enough office support and things. Healthcare is a team sport. They'd be like, why don't you head down the hall? We're going to get you in touch with one of these foundations and make sure you can afford that medicine. If you can't, we're going to try another one. We'll find you something we can cover. Providing free samples to reduce patient costs. So that was another strategy that people used. The problem with that strategy, of course, is you can't keep giving them free samples forever. And usually you only get free samples of things that are really expensive. That's why they're free to you. And you might be having a trajectory of care that's much more expensive. So this strategy concerns me, but you saw it out there. Changing your insurance plans. If you get secondary coverage, they pay for your infusions. Have you looked into getting a secondary? Well, we've called everywhere, but because of my age, you're too young? Yes. And then you get these really long conversations where by the end of it, they're just ragging on the U.S. healthcare system for being so complicated. And there are times where the physicians are clearly not understanding the basics of insurance. We're about to do a survey of this now, because you'd see the doc saying, oh, you've already paid off your deductible, then it should be free. No, doctor, that's when they've reached their out-of-pocket maximum. Be careful, But you see that really earnest, helpful clinicians saying, "Look, your problem here is you need better insurance coverage. Let's talk about a couple strategies now. And if that, we can't figure it out together, maybe you can talk to somebody in my office. Maybe you can talk about it with family and get some." But they really identify that the problem is this patient needs better insurance. So most of the cost conversations we came across in these about 2,000 interactions were really short, less than a minute, for 2/3 of them. And even when there are short conversations, you still saw some amount of discussion of strategies for reducing costs that could slip in pretty quickly. This was in breast cancer, so basic same. But the more cost-reducing strategies you discuss, the longer the interaction. But even then, the longer ones is that 94 seconds. So we can do this. We don't always do it well. And so I'm going to lay some examples of where I think we had missed opportunities to reduce patients' out-of-pocket costs. I know there's a new thing out for the, this is a patient with rheumatoid arthritis. For the ulcer, they had some kind of a stomach ulcer, besides the Nexium, because that's so expensive. Expensive would be, well, let me see, said the doc. We did use the methotrexate, and the doc starts talking about rheumatoid arthritis medicine. So I have a feeling that the patient had some uncontrolled inflammation, and the doctor had elicited that. And as the patient's complaining about the cost of the stomach pill, I think the doc is looking back through the chart and noticing what RA medicines they've been on already, and I think completely missed that they'd complained about the cost of the ulcer pill. And I mean, we can't pick up everything, but if any of you seen those invisible gorilla videos, if you haven't, just Google invisible gorilla and watch them. And I won't give it away, other than I'll give it away now. It's a phenomenon called where inattentional blindness, where if you're paying attention to one thing really closely in the world, you might miss something else. And so people who are driving motorcycles and get run over, it's not because people didn't look, it's because they were looking for a car. I mean, the same thing with people like me on bicycles. That's why I bicycle in fear and paranoia, because they're looking for a car, they're not looking for me. And if we are looking for people's chest pain complaints, or we're looking for how active the rheumatoid arthritis is, or something like that, and we're not having our antenna up for costs, then a cue like this comes out and we miss it. And so you have to have your antenna up for that. Then there's clinical distraction. I'm just assuming every hum that you're about to see in this is filled with the sound of computer keyboard clicking. I'm drinking a nutritional supplement I'm supposed to take every day. But I'm trying to stretch it out because it's a bit expensive. Yep. So anyways, I'm developing anemia. I eat high protein food right now. Level 5 visit. Drinks and protein. Okay, so they heard a word. And that sort of thing. Okay, let me take a look at this spot. They never went back. So this is a person whose cancer is far enough along that she's needing to take supplements to maintain her weight. These are super, if you don't have good nutrition, almost every other medicine you take really doesn't help much. She can't afford this basic nutrition, and the doc missed out on the fact that she couldn't pay for it. So that's really tragic. Then we talked a little bit about the frustration people have with the system. Sometimes it gets the best of them where they never return to the patient's cost concerns. What else do we need? The Restoril, folic acid. Not the folic and the Restoril. They, insurance, won't approve that one either. I don't know why. Well, those insurance companies, they don't want to pay for anything. I know. Now they're bonding over this, right? For anything. I also need the Tylenol 3, and then they move on in the visit, and they never get back to the other things that the insurance company wouldn't pay for. So good bonding moment. You probably had high satisfaction with the encounter, and they yet didn't address one of the most important concerns patients had. We'll see if the insurance company is going to pay for your BRCA test. How much does it cost to have to pay for it? Oh, we don't want to talk about that. Well, but she did. And I think what's going on here is a caring physician who's thinking, this person's early enough in their breast cancer diagnosis, they still haven't gotten the genetic test. So there's probably a lot of anxiety they've got. Now they're talking about financial concerns, and they're thinking, those are usually really well covered. I don't want them to worry about money, so I want to just tell them, we don't want to talk about that. Like, don't worry about that. But in fact, they are worried about it. And if you don't address that financial concern, they're walking out of the office that much more worried. So this is just something we have to just help people understand what is going on in the patient's head so that they can address their emotional and financial needs, right? Then I think there are times where cost comes up and the patient tries to poo-poo it because they're embarrassed to talk about it. I mean, it's embarrassing to talk to your doc and say you can't afford something. And so when they start trying to say, I'm okay, doc, we can't accept that too readily. If someone says, oh, but I've got a little chest pain, but I'm okay, doc, I would never accept that. I would like drill down to find out what's going on, right? That's what we do. So the Thai curve, we haven't given you for a long time, and these are pills. If I remember correctly, you've tolerated rather well. I think so. I think I did. And your insurance had no problem paying for it? Well, we paid. They paid. So they're complaining about the coverage. They paid well. There was a lot of copay, but that's okay. That's not a problem. No, you mentioned how high a copay was. That means it's a problem. Just go on with that assumption, please. But they didn't. Assuming coverage equals full coverage, and I think this is, again, physicians not understanding the system well, like just you finish your deductible, you're done. No. It's covered means that they're not going to pay 0%. Insurance won't pay 0, but, pardon me? Or they apply it to your deductible, so it could be on you, or even you've had your deductible, you might have 20% co-insurance for it. So, but yet a lot of docs would talk about, why do the genetics testing? See if there's anything else to worry about. I don't know. It's super expensive. The genetic testing, yep, no. Insurance should, it should take care of it. No, but they're trying to say, yeah, insurance should cover it, but we don't know the details of what their responsibility is. Assuming copay assistance and free samples resolve cost concerns, and as we talked about earlier, that often that's temporary, and people, when they get copay assistance, they have to re-up pretty frequently. There's means testing. There's often, they come in complaining about the forms they had to fill out, and that there was lapses in the copay assistance coverage because they didn't refill out the forms in time. And then failure to consider less expensive alternatives. This is the person we talked about earlier, OxyContin for metastatic bone pain, had to spend $200 on pain meds, and the doc suggested a much less frequent. I mean, you can save money on your pain meds by taking fewer of them. How about trying an affordable narcotic? And maybe a palliative care consult, too, because there might be other methods. OxyContin is an unnecessarily expensive medication where we have equally good drugs out there. And so we can't forget about that. They weren't all this bad. And just to give you the good news, I want to give you an example of how well this can go and why I think we can get there with more work. And then I really want to open it up to your thoughts. And then if we have time, I can tell you how other ways I think I would solve this other than just the encounter. But here's what I'll say. This patient comes in, doctor, I remember you had problems, the doctor says, I remember you had problems getting medications because you're on Medicare or Medicaid. Doctors don't always know the difference between that. But first off, this already shows that they had a cost conversation on an earlier interaction, which is great, and that the doctor remembered it and revisited it. Fantastic. Well, I'm on Medicare. They haven't been treating me fair on, this is a transcription that says Medicaid. They cut it off, they get so high I can't. And so you end up with the bill a lot of times, right? I mean, that's all I got is the bill. What I'd like to do is to start you on with something simple. I want you to have quality of life. I want to give you something that won't be very toxic, not trying to cause a lot of trouble, at the same time effective against the cancer. I'll find out about your insurance coverage and whether you can get this medication, and then we'll go on from there. So first off, there's reassurance. They're addressing the emotional needs and the financial. They're saying, I'm not going to get you something you can't afford. And they might not have all the details written out here or figured out, but maybe that's because they're going to have a little bit back and forth with the billing person and then coming back. But they're really letting the patient know, I hear you, and I'm going to address this. Well, I can't do nothing. I don't have any control with what? The Medicaid? Yeah, well, I'm not too worried about that. We'll figure out some way to get it. So they didn't just say, I'm not worried. So they're not worried because they're going to figure it out. Just like we've gotten you your other medications, we can get you this medication. So I think that's fantastic. I think there's a lot of this that does happen out there now, and I think it's happening more and more often because docs and other clinicians, we're seeing this more and more often, and so we're having to learn how to do this better. So my bottom line for just how to talk about costs and why to talk about costs is simple. As long as patients have significant out-of-pocket expenses, which I don't see going away anytime soon in this country, clinicians, healthcare providers more generally, need to help patients factor those costs into their medical decisions. We do need to improve insurance choice. I think one of the reasons we run into out-of-pocket cost issues is that patients get plans and don't realize the out-of-pocket costs that are associated with them. There's a lot of Americans, after reading a definition of the word deductible, still think that the higher the deductible, the better, because they deduct more from the price of the insurance. It's just a hard word to overcome your intuitions about what it ought to mean. And so then they end up in high deductible plans and then are stunned when they have high out-of-pocket costs. I do think if we're going to have any kind of legislation to push people into high out-of-pocket plans, or I think any employer that's mandating high out-of-pocket plans, we were talking about this a little bit on the break, employers should be demanding price transparency. When they decide that Aetna is going to be the group or United is going to handle their employee benefit, their healthcare benefit, they should say, you're only getting our business at our company if you get price information to our employees in time to inform their healthcare decisions. So I think employers need to push hard for that, and or legislators. Why not just mandate that the prices are out there? The state of New Hampshire did it, and now you can go on their website and find out the exact cost of almost every basic test and treatment out there that's looks at what your insurance coverage is and what your costs will be. Ooh, we talked about whether you should screen patients for financial distress. I don't know if we need to screen as much as we should assume everybody's paying more out of pocket than they want to or have to, and we should just make these just routine things we discuss. And the more we just treat them as routine things, the less shame there's going to be about discussing it. You just say, ask every patient of mine if they're facing high out-of-pocket costs, and so I can, because the system's so confusing, help me understand your costs, and maybe we can find a way to improve that. And I do think we need to train clinicians to talk about out-of-pocket costs, and I'm doing work on that right now, as are other people. So that's just my quick take on it. I'm really eager to hear your thoughts and your comments, and then we can have a nice back and forth. Thanks. Yeah.
How's that playing into some of your research? I think it's part of shared decision making.
It is, and so I'm sorry that I just assumed that rather than said that. The comment really was, where does shared decision making fit into this? This is about shared decision making. When you're trying to factor a treatment side effect like cost into medical decisions, that has to be engaged in a way that's about shared decision making. It's understanding you're not assuming how a patient would make a trade-off about cost and quality. And so you'll see sometimes a patient, there was a patient who came to Duke, saw an oncologist, and the oncologist assumed that getting the medication at home in pill form was way more convenient than coming in and getting regular injections and infusions in the oncology office. The person had a distance to travel. Assumed that until the patient had a recurrence of the cancer and said, I can't go back on chemotherapy. I exhausted my life savings paying for the first round, and the oncologist realized they would have had almost no out-of-pocket expenses if he'd come to them for care because of that whole idea about whether it's a medication cost or a hospital cost or something. So you can't assume what people want. You can't assume how they'd make a trade-off. You get the information on there and let them know the right decision depends on what what matters to you. Amen. Yeah. Other thoughts, comments, questions? Alan, yeah.
So I was going to set you up to maybe dive into the other area that you mentioned. What is ideal? If you had your magic wand, what would the ideal world look like in terms of, and I'll be a little more specific, the clinician's role in these cost of care conversations? So how could we do this better?
Yeah.
Specifically within the clinic, so that routine, and I think there's a whole nother world that's not about how you do this within the routine clinical visit.
Yep.
But let's focus in on that piece of it specifically, because that's where the research was. So how would you propose doing this better within the routine sort of clinical visit?
So I'm a big believer, and this is your complicated things to do, but in trying to align out-of-pocket costs with value. So the things like you hear about value-based insurance design is one version of this. So right now, people's out-of-pocket costs are generally aligned with cost. The more expensive medication is, the more you're going to have to pay. But somebody with rheumatoid arthritis who did not get good response to a less expensive drug like methotrexate needs a biologic therapy, which is going to be really expensive, but it's high value. Why should you make out-of-pocket costs a barrier to getting a necessary treatment like that? Versus, there are times where, I'll get too personal here, but my wife has metastatic breast cancer. She's on $300,000 of medications a year. When I looked up the research on the drug she's on, there's $600,000 to $800,000 per year of life that they bring. These are not good values. Now, I'm glad that our system is covering it, right? It's ridiculous for our system to cover it. We should have it, if you know that as a patient, when something brings high value, value means a lot of benefit for how much the thing costs, that we want to encourage people to have high value medical care, and so we should dramatically reduce out-of-pocket expenses. But when the care that we receive has a very high financial cost and a medium or small amount of benefit, I'm willing to let out-of-pocket costs rise, and we're going to have complaints. And if, patient advocates are going to say, well, now they're not able to get a chemotherapy because of the cost, and I'm okay with that because it's a huge societal cost if we don't have pressure to reduce pricing like that. And I think then what does that mean for the clinician? It means that I know when something's really good value, you're going to be able to afford it. That's a given in the system. And when something's really expensive, I can tell you I can talk to you and say, the reason this is going to cost you a lot of money is because it's not the greatest intervention we have. So I think that would be a lot easier for clinicians. Otherwise, we're in the situation where, I know this would be really great for you, but it's really expensive. Maybe we can find something that's crappy for you, but at least it's cheap, which is a terrible situation to be in.
So I think we have one last question,
Awesome.
and Jerry has his hand up.
Peter, just fantastic presentation. I would like you to maybe comment on, as you're informing people about costs or maybe having discussions about value in one way or the other, how replete do you think our knowledge base is that we can actually offer information saying, this is really expensive, but really worth it.
Yep.
This is really expensive. I don't
Terrible.
really know if it's worth it.
We don't know it. Absolutely. So,
right.
So these conversations were ones that nobody asked people to talk about costs. This is where patients came in and we saw 30 to 20% of the time costs came up, and they were often not prepared for it. We're working right now with several groups of physicians, and we're going to ask them to hold these conversations with patients who are under financial distress. And then we're going to try to problem solve with them and find out how can we make this easier for you to sort out. So when we work with the rheumatologists, I have a feeling we're going to end up working with the clinical pharmacists, and we're going to have a couple cheat sheets that kind of let them know which plans that cover 80% of people in North Carolina have which out-of-pocket costs. And just having that ready will make it better. But we aren't prepared to have a lot of the best conversations right now because it's so hard to get the information we need. Thank you very much.
Yeah,
really
so-
looking forward to the panel where we're going to probably follow
Thank
up.
you. And please join me in thanking Peter Ubel. And Peter, there was no loud chewing. So would the next panel please take the stage?
Nice to put faces with names.
There. Amy. You're Mary.
I don't know. Am I on? Yeah. I think that's just me normal loud, but anyway. I'm so excited about this. I was so excited about the topic, but this morning has been so rich with information, and we still, I think, have more questions than answers, but that's a good thing because we have an opportunity to fix this thing and make it right before we begin it really executing and implementing. So we have a wonderful panel here today. This is my first time meeting everybody on the panel except last night. I think I met Rita.
Yes.
So I'm going to call everybody by the wrong name. I'll try to do it right the first time around. I'll get you right, though, Josh. Guess
Thank
why? You know, but really, really wonderful panel that we have here. And are we going to have something down here with them? Well, we'll just chat for a minute. Something that I was going to do anyway, and I'll do now. I take notes. I'm a writer, and I used to do a lot of interviewing. So as people are talking and things are interesting to me, I'm always taking notes. So I'm just going to share a few of a list that I made of topics we talked about this morning and some of the things that we still need to resolve and things that I just found, terminology that I found very interesting. We talked about harm versus benefit. Really important in this conversation because we're having these conversations, or we want to institute these conversations for benefit. But we have to understand that if we don't do it right, there could be harm. We talked about, we had just really inspiring patients up here this morning, survivors who talked about their stories. And some of the things that came out were insurance, caregiver, support system, or the lack thereof. And importantly, the people who were up here this morning had a support system. Think about and it was difficult for them. They could not maneuver this system very well. Think about what it means for people who don't have that sort of support system. Talked about logistics, the ability even to move to another city because you need to do that to get the best care, or to commute and so on, which could be an issue. Talked about life flow and workflow, which are two different things. A life interrupted, lost opportunity costs, dollars, time, stress, paperwork, all of those things that impact what you want to know about cost and what you need to know. Financial toxicity, which has sort of become a catchphrase. I don't know that there's been a lot of movement in terms of what we do about it, but we talk about it a lot, and we're trying to move forward. One of my daughter, who happens to be my business partner, my oldest daughter, one of her favorite phrases or things she says to me if I get bogged down is sort of keep it moving. So we're going to keep it moving here. We're going to talk about what the issues are and the barriers, and we're going to move on to solutions, or there's no point in our being here today. And you're lovely people, but we want a purpose. We want something to come out of this. We talked about, and this is a really important point, the initiative sometimes to get answers to some of our problems or some of the issues that we're having must come from the participant, from the patient and the caregiver. So again, you have to have the wherewithal to know that. You have to have the ability to know that you can ask certain questions. So certain populations are further disadvantaged. We talked about the cultural context for money discussions. Briefly touched on palliative care. Talked about huge and mounting bills and how we have to even learn about new technology, such as getting screenshots in order to prove that we saw what we saw. Didn't talk much about this, but talked a little about documentation, and that is the need to keep information, that you have to keep things, even things as small as Post-its. I think someone mentioned keeping Post-its and sending them forward. So those are kinds of things that come into this whole conversation and things that we need to think about. Talked about some of the emotional costs and fears, and that whole statement that I know Gwen talked about a few minutes ago about the statement that you can't afford to live. You just leave that hanging in the room for a minute, the idea that you cannot afford to live and that you had to make certain kinds of decisions based on that. And then all the non-monetary costs, and I'm almost at the end of my list. I got more stuff, but I won't say all of it. Infusing the complexity of cost into caregiving. That's infusing it into it. There was dipping into savings, the fact that people have to sometimes dip into savings. This, of course, assumes you have savings to dip into, and that is not always true. And do you really want to know about costs? I'm going to mention a little encounter I had with someone who said they really don't want all this cost information shared. Cost conversation preferences, and the mixing money and medicine. That people are sometimes, you're uncomfortable talking about money, but then when you got to mix it with medicine, that's a whole different thing altogether. And patients not wanting to receive less based on their discussions about cost. And there are lots of other things, but I'll stop there. I just wanted to mention a few of the things that I heard this morning that pertain to us talking about incorporating these discussions. We've got to resolve some other things before we decide how we're going to incorporate them, but we're going to talk a little bit about that today. Generally, before these kinds of sessions, if I'm on a panel, I do I guess I would say a grossly unscientific survey of some kind. I didn't do one this time, but I happened to have a conversation with someone about 3 weeks ago, not thinking about this particular panel, just a conversation between patients and some healthcare providers. And two of the patients who were sitting at the table said they did not want their doctors to have, their medical team to have any information related to them and their finances at all when they were making medical decisions. They wanted every decision made on their personal health status and so on, that they were leery of having other cost information in there for fear that it wouldn't simply mean that someone would assist them in terms of getting the best care, but that would in fact determine the kind of care that they got, the medication that they got, the pain management, and so on. So there's a lot that's embedded in that we're going to talk about here today. But this morning was just so rich with discussion, and now I'm going to stop talking so much and do what I'm supposed to be doing here, which is moderating and facilitating this. So I'm going to, again, I'll just sort of go down the list here and introduce people, and you can see here that we have Kim Irwin, who is here, and she's an Associate Director of Population Health Sciences, and she's at the University of Illinois. And let's see, April is here, and she's at George Washington. And I think you're involved somewhat in student medical education and with the residents and so on as well. And then Rita Matthews, who talks to patients every single day. And I think for 14 years has been working with patients here with NPAF. And Amy Russell, and I think you deal with rural populations and underserved populations as well in North Carolina, I believe.
Yes.
Okay. And then Joshua Seidman, whom I will get right from now on, is at Avalier Health, and I'd like for you to tell us a little bit later about that wonderful infographic and how we might incorporate some things there. Okay. So I think I would really just like to start, I think, with Rita. Okay. And the reason I'd like to start with you is because every day you have these conversations. What we're going to talk about now is, this morning we talked about the who, what, wheres, and so on. Now we're talking about the how. The how and somewhat still the why. We know we want to do it, but what's the outcome from it? And so since you every day, you're a case manager, and every day you talk to people, I want to know how you facilitate these conversations about cost and what kinds of things are people talking about and what kind of help do they need?
Well, when it comes to the type of help that they need, it's very vast. You know, a lot of times patients call and we'll ask them, you know, how can we best assist them when a case is set up and it's assigned to me? Sometimes they say, I don't know. So, and that's very common to hear. And so at that point, I just break it apart piece by piece. And then because it gets so overwhelming, the anxiety comes in. The day-to-day life changes because the typical patient that we help with at the Patient Advocate Foundation have life-threatening, debilitating diseases. And many of the patients are cancer patients, therefore the drugs are very expensive. When that happens, you know, a lot of times, like, you know, earlier we were listening to about the whole stack of bills. They'll say, I have this whole stack of bills. I don't know what to do. And I'll tell them, okay, we're going to look at one bill at a time. What I want you to do, I'll give them a homework assignment. I want you to go through the bills because many of them are duplicates. Typically, the medical billing department, you know, will have the cycles where it come out every 30 to 45 days. They may have 3 or 4 of the same bills. I want you to get one bill from the medical facility, just one. And we'll start one facility at a time. I'll facilitate a conference call with the medical facility, see if they have a charity assistance program. You know, I'll go through the income guidelines to see if it's something that the patient will qualify for. Also, what I do is I see if it's a medication concern, is there any pharmaceutical patient assistance programs available for this medication? Are there any national copay assistance programs available? And sometimes we also have to look at lifestyle changes. For instance, you know, we were talking about this over dinner last night. If you can't afford a copay of a medication of $50, sometimes, you know, let's look at your everyday expenses. Because when a life-threatening disease does affect a person, it affects the whole family. It affects them emotionally, it affects them spiritually, financially. It affects the entire person. It's not just one aspect of their life, it's the entire life. So when I look at that patient, I look at their whole life, you know, And once they open up and they realize, oh, it's okay, Rita's here to help me, that's when they let me in. Once I get in, we're able to pull it apart.
So you have these conversations daily?
Every day.
Absolutely. Every
8
day.
hours a day, every day.
Every day. And we're trying to make sure that we're talking about incorporating these conversations in the workflow that all of us have relative to patients and interacting and so on. So I'm just curious, say, April, how do you train health professionals such that they might normalize these conversations into their workflow, that it's something that you do all the time? Someone used the word normalize this morning. I think it's absolutely what we're talking about, making this the norm.
Yeah, I like that comment too. We do a lot of different things. I don't think we're unique at GW, but one of the things that we will often do is actually practice these conversations with standardized patients. I think sometimes in the healthcare environment, when you're face-to-face with a patient, it's really a high-stakes conversation. And so having our trainees practice these conversations in more low-stakes environment can be really helpful. That way, if they say something very inelegant, the standardized patient can say, oh, don't say that again, and they've learned their lesson, rather than a patient never coming back to see them again. So I think that sort of training has been very helpful for many of our students and residents, learning how to initiate the conversations and react to the different responses that they get.
When you say a standardized patient, what do you mean by that?
These are actually actors that come in and assume a patient role, and they can be quite fun for anybody that's ever interacted with them. If you do a difficult patient encounter, they might, yell at you or something. They will really go there. So, and I think the cost of care conversations are really helpful too, because they'll be resistant at times and really make the resident dig for this information.
Does anyone else participate in that, in anything that would amount to training? This is actual training program that you're talking about here. And when we talk about incorporating and normalizing these kinds of conversations, one of the things that's on this infographic that I'm going to ask Joshua about in a few minutes is the idea that we, in fact, have to normalize these discussions. We have to train. We have to have an educational component and so on. For instance, Amy, how do you incorporate that into your practice?
Yeah, I'm faculty member at Mountain Area Health Education Center in Asheville, North Carolina, and that's a small part of my job. But when I first joined faculty 5 years ago and I did my inpatient work with the residents, I had previously come from a community health center setting where we were very attentive to costs, because almost 50% of our patients didn't have insurance and they paid everything out of pocket. And I actually got a little bit anxious being in the inpatient unit, and we had one patient that was uninsured and then a variety of different insurances, because we were having these discussions and there wasn't attention to cost. And so I asked the residents, and I do this, so come back to me. We usually have a teaching element in our morning rounds, and I asked them to come back and tell me, with a particular patient where we had decided to order an MRI, or we were treating them with a certain medication to bring me that cost back. And the first time I did this, I had a very conscientious resident very upset that she was not able to accomplish that. And it turns out what the process had to be is that we had to get a consent from the patient, and after their discharge, we could get their bill, and that is how we could find out what the cost of care was. But, I hadn't been through that process before, and I think it's a good way to help people understand that they need to be attentive to it, because, and of course, we learn that lots of things that we're doing as we're ordering them in the hospital have impacts on patients and out-of-pocket costs.
Some of this discussion goes to the fact that one size does not fit all. We talked about different populations and the different demographics and different diseases. And I know that you work with, I believe, a rural population often. And how does that, the context of culture, and there's just cultures, different kind of cultural nuances in various areas of the country and different parts of the country. And so in rural areas, in rural North Carolina, is there a different kind of stigma perhaps against, you know, in terms of poverty and in terms of your ability to pay and willingness to talk about these things?
Absolutely. And I'm in Asheville, North Carolina, but I'm the medical director of an ACO, and we cover all 18 counties of Western North Carolina. And many of our primary care providers are short in support, and they take care of a lot of patients. And people who are really unable or unwilling to travel to get specialty care, they don't even necessarily, I mean, they don't have internet access in a lot of places. So if we were to try to engage them through telehealth, which we've been working on, they may not have access to that. They're uninsured or underinsured and have lots of barriers financially. And so really navigating that rural environment where we try to bring as much to the patient and to their medical home virtually or through consultation has definitely been a journey. And they're culturally, I mean, Western North Carolina's Appalachia, there's not a lot of trust sometimes of the health system. And where that comes from culturally is, or just not a belief that pursuing a lot of medical care is a priority, particularly preventative care, and particularly when it has costs. And so really engaging people in upstream preventative care is a lot of effort as a network.
And just a question for Kim. I'm really interested in what you do. I'm interested in ethnography, and I think some of what you do in terms of designing systems that are for healthcare solutions, I mean, designing solutions for healthcare system problems is really fascinating in the way that you do it. Can you tell us a little bit about what you do and how that might affect, for instance, in the context of different kinds of populations and demographics and so on, how you decide what's appropriate? How do you get the information that you use to build a solution? I know you're not big into focus groups, for instance. Okay.
Wow, information has preceded me. It's a very specific thing to know about me. Yeah. I see, okay. So for those of you who are picking up on this, I'm a designer by training. I was a professor of design methods for 10 years and have been a practicing designer for the better part of maybe, let's not do that math, a while. So typically we do use ethnographic practices to understand the context. And I think if I had one kind of word I could underline, it would be understanding what happens in real life, not what happens because we think it should happen, not because of what we plan should happen. So what that means is that we will go into the context of care. It might be a clinical setting, it might be an outpatient, it might be a hospital. We will go into schools to understand how care gets translated for children into a school setting, which, by the way, they spend much more time in school than they do with their parents. So it's an important context for care. And we might go into people's homes, and that's a very informative space to be in, because there are lots of things that people wouldn't necessarily share with you, but you can see when you are in their homes. And they might not think to share with you, because to them it's the water they swim in, and so it doesn't seem distinctive or worth sharing. So in the work we do, we tend to do extensive, we call them contextual interviews, where we go into their homes and we might spend a couple of hours with them. And we do a lot of activities, and those activities are designed to help people who are not doctors, people who are not used to even being interesting to other people. They don't expect that you care about their lives in the kind of detail that we do, to help them tell their story. So they might be mapping activities, done pediatric asthma work, where we said, let's go on a tour of your home and tell me what you think are safe zones for your children. And that's very revealing. You start to understand the mismatch between what they know, what they think is true versus what is actually true. We also have done remote ethnographic work, hanging cameras, video cameras in settings to watch natural behavior between patients and providers. It's always done with the appropriate consent, by the way. It's no spying. And there are other techniques where you can really see how people behave under normal conditions. Whereas if you just ask them, especially ask them out of context in a focus group, they will tell you parts of it. It's not that it's not true, but it's probably not the whole truth. and sometimes they tell you what they wish was true, which is a normal human response when you're in a social setting, is to bond with the people next to you.
That's really quite fascinating, because I know we tend to, we want to assess things and we want to make sure that people can speak for themselves, but we think that, for instance, when we have focus groups that we do that, but I'm not a strong believer in focus groups, the power of them. I think they're useful. However, I think that seeing people where they are and allowing them to speak for themselves and so on, you get a different kind of perspective. And thinking about that, since we've talked about training and how we're beginning to train people, and talked about the different contexts and the fact that some of us every day see people, that's what we do every day. We talk to people about healthcare and about the costs and so on. I'm really interested in sort of pulling all that together and thinking maybe, Josh, if you could tell us a little bit about, has everyone seen this infographic? Maybe before I start talking about it, has everyone seen this infographic? It's in the book. Okay.
Actually, that one's not, but...
Oh.
But that's all right. I actually have a few copies I can hand out too, and it's available on our website.
Sorry, I thought
but I can explain what.
If you could explain this lovely infographic that nobody has, and so I've blown it, but
it is.
It's on the website.
And yes. Yeah.
And it really talks about steps to improve cost of care conversations, and then more context on the patient. Clinician cost of care conversations. It's really quite good.
So this really emanated from the beginning of the work that we did with the Robert Wood Johnson Foundation on this cost of care conversations project. And Emmy and Avalier sat down and started talking about how do we understand sort of the full spectrum of what needs to be done to normalize these conversations. And we said, the first issue is that, and this is from our initial research with about 30 or 40 experts, as well as patients and others. Originally what we found out was, clinicians many times said, this is not my job, or, this is not why I went to medical school, et cetera. And so part of it was to get them to understand everything we've been talking about today, that it absolutely interferes with your ability to provide good care if you're not having these conversations. So the first step was really just education. But if you get to the point where you have convinced clinicians that, yes, this is part of my job, then they say, kind of what Helen said before, I have no idea what things cost. How can I guide my patients if I don't know what this MRI costs versus the one down the street, or this drug versus that drug? So they felt in the dark. And so the second thing that we said you need is resources. You need tools and resources that can help provide transparency to understand that for both the clinicians and the patients. But just having those resources not integrated into care delivery, they'd just be sitting there, or it'd be too much work if it wasn't baked into the normal part of care. So we said we got to integrate those into clinical workflow and into patients' life flow. And I think, it's understanding both what do clinicians need in order to make this something that they can easily make part of their clinical encounters, but it's also how can we make it convenient for patients and caregivers to access it in a way that meets with their daily lives. And then all of that said, even if you have that, you still have to do a lot of training. And we were talking about, we got to get to, go upstream to medical school, to residency, et cetera, to make sure that this is something that is baked into that kind of training. And then finally, if we are going to make this something that is expected, there also has to be accountability. And for accountability, we need measurement. We need to figure out how to measure whether this is being done and hold providers accountable for that. And so ultimately, the sixth phase really is around scaling this.
I don't know if it's possible. If it's possible at some point, if we could actually put the infographic up, it would be lovely. I don't know if that's possible. Okay, that's not possible. No, I understand. If it's possible, I'm not really technologically, I'm challenged. So I assume other people can do things I can't do. So anyway, but the infographic itself, when you get a chance, please look at it. There are, I think, 6 priority areas, and it really takes you through all of the steps necessary. One of the things that I just sort of like to throw out to the group that is separated is both, there's an education and engagement component, but there's a training component as well. And sometimes we shove those together, and that is not I don't think, a very productive thing to do, and I think it's wisely been separated here. So as we talk about incorporating these conversations, what's the difference in educating people about this and making them more aware and the training people to do it? How would you separate those two? Anyone on the panel?
Well, I can speak to why we separated it. One is really the basic just understanding of the fact that this is important and that this needs to be done. A lot of the conversation we've had today. The training piece is, well, okay, I understand it's important. There are some tools out there. We've figured out ways that we can think about how this can be integrated in care delivery, but that still doesn't make it a practice. And telling people that something is important or that you should do something is very different than making it something that is a normal practice. And I'm sure people who spend their lives training clinicians probably have a lot of experience with that.
I'd like to add to that, because I think that one of the things that I saw in the work that we did for Robert Wood Johnson is that there's a component of belief that something should happen at all, whereas training is how something should happen. And I think that is definitely a barrier in cost of care conversations right now. Is not just an ability, but an agreement that it should be happening.
And various organizations groups are now having conversations within the organization. I know that NCI's INCOR recently had, I guess it's been several months, had a series of webinars, and they called it financial toxicity, which is the catchphrase we hear when we're talking about cost of care. And their focus was on research, having a research base for the need for this, so that it's not just anecdotal, so that we have evidence base. But the other part was to train people so that they knew how to have these conversations. So part of the issue with this is not only if we decide this is a thing we want to do, and I think that's the consensus, is how do we, once we get across past the education part, which is, it's really making people aware of it, making all parties, all stakeholders aware of the importance, but then becomes the part of how do you train people? Some of you have talked about ways that you train, but what are the effective ways to train? What are the kinds of things that people need to be aware of, particularly when these are sensitive conversations?
Before that, I'd like to say that I think that you're right. We need to do education. But I don't know, Amy, maybe you can weigh in on this. I find that our trainees are already aware. I think with all the healthcare debates out there, the ACA, my trainees want to know how to have this, and they don't need to be convinced that it's a problem. They are very unsure about how to approach it, but I think we have, as a society, done a fairly good job educating our young people that this is actually a problem.
And I'm going to guess it varies, because on the two webinars that I was a part of, there were people who were health professionals who were really reluctant to have these conversations, but mostly because they didn't think that they had necessarily they didn't have the tools. They weren't sure what they could ask. They didn't want to offend anyone. And I think that is a part of it. I think this whole idea that we have to have the right tools and we have to be consistent. And someone said in the earlier panel that they would be able to say, if they do this across the board, if you really incorporate it, you can say to your patients, we do this with everyone, so it doesn't become a personal kind of thing and a personal affront. So I think that might vary a bit. Did you?
Yeah, I would agree that at least this generation of residents has a different perspective on cost in healthcare. Tools is really important. I hear it may even be today that CMS is coming out with an online tool where you can actually look at the radiology costs by region. So those kind of things are going to be critical. It is about actually understanding that. I think one of the bigger issues, which is why I think we're talking about workflow, is that at least with the primary care workforce and those who are involved in managing cost and value, our primary care workforce is very stressed. We counted, we have 154 quality measures we have to report. We are really pushed to push volume. Having the time to actually have conversations with patients it's very, very difficult. So there's another fundamental issue in primary care that has to be addressed, because I think if I told people they had one more thing, checkbox they had to do, and one more thing to add to their workflow, they they would be resistant. that may be where some of the resistance comes from, because they already feel really pressured to do a lot in a comprehensive visit.
I think you're absolutely right. And one of the questions I'd written is, how do you actually ask people to fit another thing in? When you walk into the office, it is very clear that you have your 10 or 15 minutes. However, I want to say something else that affects this conversation. Patients are pushing back on that 10 or 15 minutes. I have to tell you this, that they're coming in with questions and lists, and some of them now have to do with cost, those who are brave enough to do that. So there is some pushback on how much time that will be spent with them. Another question, or just a general comment or question or something, is as we move forward incorporating these conversations in workflow and educating people and training people and having the tools and all of this and having measurements and so on, what are the precautions that should be in place as we move forward to make sure we do it right? Because we have a chance to do this right. I think if we go in like, I'm really awful with cliches, so I'm going to say it wrong, like a bull in a china shop or whatever those kinds of things are, and don't do it quite right, will do harm that will be hard to correct. So what are some of the precautions you think we might need to take as we move forward, things we have to be really, really consider?
I would like to volunteer, mostly because my work was with low-income patients on Chicago's South Side. And one of the things I keep hearing from people trying to figure out how to make this happen at a systematic level is, well, we should do screening. The patients that we spoke with do not want to be screened. They don't want to be special. What we heard from our low-income patients was two things. I worked really hard to get into this practice. So it's high-risk pregnancy. I am here because I care about my baby, and I want to have a healthy baby. And so if I don't want to be seen as not belonging here, so I'm afraid you're going to discover I have a cost problem. So I'm not really interested in putting that on the table forthright. The second is those women were also less likely to avail themselves of resources that weren't available to everyone. So if everyone was getting a free breast pump, that was great. They would help themselves to that. But if they felt somehow that they were being offered something that, because they, really didn't match the normal patient population, they were going to be resistant to taking advantage of that. And so I think when it comes to low-income patients, it's very important to them to be seen as just like everybody else. And so I think there's some extra caution that needs to be put into that. And I could tell you lots of stories about that, down to the fact that if you're a low-income patient, you're probably already being put into a clinic that is being seen by residents and not attendings, because that is how they manage Medicaid patients. That is how you manage low reimbursement patients. And so they're not even seeing the same doctor all the time. So the idea of having a cost of care conversation with your doctor, you'd have to have it every time you showed up.
That's a really interesting point, that we sort of assume in this conversation somewhat that you're having consistent care with the same person with whom you would form a relationship and some trust. And we talked about the wonderful relationship that we saw exhibited a few minutes ago in the previous panel. But I would imagine lots of the patients who come through the NPAF and through lots of other organizations, quite frankly, that's not the case. So we have to think about that as we go through this, that we're talking about some very vulnerable populations who don't have a doctor that they see all the time and that they trust already. And the point about making sure that everybody gets it, if you get it, is similar to, if you think about it, the analogy might be the free lunch program in this country. In many places, originally you had to come with a ticket, and so you were called out. So students didn't want it. They literally would not eat, the older students, rather than get it. And so in many places now, for instance, in New York City, where I was living for a while, all students get free breakfast. If you come in, they have breakfast for any of the little ones, at least, who come in and so on. And so it might be the same kind of thing. So all of this, some of this gets at when you're talking about people being willing to accept what we think we want to offer them. We also have to think about, how we make these things acceptable to them. And part of that is with this building trust and making sure that people feel comfortable. How do you handle the feeling of shame that might have to do with income level and with inability to pay for medication. Most people are probably not just coming in saying, I didn't pay for my medication. There's also that fear, and I'm assuming that you know this, that if you tell your doctor that you're not following instructions, you might find you don't have that doctor much longer. So how do you deal with those kinds of things when you're talking about cost of care, building it into your normal conversations that you have?
One thing I was actually thinking about is when we started talking about HIV screening and how we really stigmatized patients. And we eventually, as a healthcare community, came out and said, quit asking people their risk factors, just screen everyone. And I think that gets at some of what you're talking about, where you don't actually want the provider that they're seeing to make those assumptions and only screen people that they think might have it. The other thing I heard today, which was when we get to that point where people are not adhering, that is the tip of the iceberg. Many people are sacrificing other things that we will miss if we don't start screening. But the final thing I'll say on this is providers cannot do it alone. This is where the team has to come in, and having people like Rita or social workers or your wonderful MAs or nurses in your clinic can help. And I actually find that patients often tell my MA much more than they tell me, and she's a great resource for that. So those are my snippets.
Rita.
Yes, and I just want to piggyback off of what she just said. I do get patients that contact the Patient Advocate Foundation, and they do disclose a lot more to me than they would to someone face-to-face, because I am over the phone. They don't see me, so they disclose a lot of information once I do gain their trust. And there are several patients who are not able to afford their medications. Matter of fact, earlier this week, I talked to a breast cancer patient. She says, hey, I've been taking a pill every other day because I just cannot afford the medication. Right during that conversation, first thing I did was I looked up the cost of the medication. She told me her cost. I looked on GoodRx to see if there was any cheaper medications, and there wasn't. First thing I did as a case manager is I reached out to the provider's office and spoke to the nurse. And actually, I had to leave a message and requested a more affordable medication for this patient. And that's what they actually looked into. And in essence, she was able to get it. But the patient herself did not want to do that because it was the fear of being turned away. And I had to let her know that it's okay. You're not alone. And see, once patients realize that they are not alone, you're not the only one who cannot afford a medication, it puts their mind at ease. And she thanked me so much during that conversation. For me, it was something small, but for her, it was very big. And it was really, really a positive call, positive resolution.
I think language is everything when you start talking about these things. And you talk about, you don't want to use the word cheap medicine. When you say less
more
expensive,
affordable.
more affordable, all those kinds of things. But you're not sure what the person is hearing when you say that. And I think let's talk just a minute about what the patient and the family might be hearing when they say, let's talk about cost of care. So we have to, sort of tread very lightly, because what I might be hearing as a patient is, I'm going to get less effective. We talked a little bit about this earlier this morning, less effective medication, or not what you would recommend, which is a little bit above what I can pay, but the next tier. And we need to make sure that is probably not what we're saying, but that's what people are hearing. And that is part of the shame is about what they earn, but part of the fear and the reluctance is about the fact that there's a belief or a sense that perhaps then you will base the kind of care, the level of care that I receive on my ability to pay. I live in Ward 7 in Washington, D.C., and anyone who knows about Ward 7 and 8 are the least well-served wards in the city. I lived there all my life, and I love it there, and that's why I'm there. And but if someone were looking at my demographics I don't know that I would necessarily, and I'll be very honest, want a doctor to look at that and say, oh, gosh, she lives in Ward 7, she probably doesn't have insurance, she probably is low education, all of these other things, which have absolutely nothing to do with me and might have nothing to do with my condition. And people are fearful of that. So how do you sort of overcome that in terms of language and how you present what you're saying? Because it'll make a huge difference, particularly when you're talking about people who are already underserved in some manner. Thoughts about how you
approach? I'd love to jump in on that, because I think that there are very few people in this room who really know what it's like to wake up poor every day. And what we heard from the participants in our study is they are reminded every day that they are poor in their community. Their gas stations charge them more money. Their grocery stores, if they exist, charge them more money. Their landlords charge them more money for terrible apartments. They want to just be someplace where being poor is not the primary. They don't want to be reminded they're poor again when they're in talking to a doctor that they worked really hard to get an appointment with. I think that part of the language issue that we found, because we tested a number of tools, and part of what we did 13 variations on our tools. A lot of what we changed was the language. And we had started out putting it out as costs, and we got a lot of pushback. We were surprised, given it's a cost care conversation project. We wouldn't have as much issue with that as we did. And we had to, we ultimately found that language that was comfortable, framing language that was comfortable for both providers and patients, was planning your treatment. And this idea of forecasting for people, what to expect in the course of their treatment. And this had a number of beneficial aspects for providers. It meant, well, they were just talking about the cost part that was a part of treatment, that was part of care, their providing of care to patients. That seemed more acceptable. And from a patient perspective, they weren't sure they were willing to talk about costs, so it allowed them to sort of tiptoe right up to the edge, look at a treatment plan and go, I can't come that many times in January. I just can't. So it allowed them to sort of set up the conditions in which people could begin to have the cost conversation, but they didn't want to call it that. They wanted to be a part of treatment and care.
And just as language and what we call a thing makes a difference, how we set up the conversation makes a difference. So in your various settings, is there any particular way, for instance, Rita, is there a way that you make people feel comfortable? Because clearly you do. You told me a story last night that was quite interesting. So you clearly do that.
Yes, and it was very unique, and I can actually share that story again. I am an animal lover, and I had a metastatic breast cancer patient that called me, and, she needed help with food. I said, okay. She said, well, I have I believe he was 8-year-old, and an 8-year-old boxer. She lived alone. She was elderly, and it was just her and her dog. She says, I said, well, I can get you Meals on Wheels. She says, no, I need food for my dog. She said, because this is all I have. I have no family. I have no friends. I have my dog. She says, it may not be important to you. I said, oh, it's very important to me. Because it's important to you, it became important to me. So right then and there, we made call after call after call, because I wanted to make sure she had peace of mind and she wasn't alone. See, if you can give a person hope, as Tammy, as we were talking about last night at dinner, that's the very beginning. And if you build on that hope, it builds a better person. Because if a person is sick and they do not have hope, they have a lot of anxiety, they cannot get well. And that's what we talked about last night. So I did a Google search, contacted several foundations. One was the Area Agency on Aging in that city. Believe it or not, there was a program through the Humane Society. After several phone calls, probably took us about an hour, believe it or not. And they wanted to know the weight of the dog, the breed, the age of the dog. And they were able to bring a month's supply of food delivered each month to this patient. And, she cried on the phone. I cried with her, too. We were both crying. It was
tried to make me cry last night.
It was a moment. It was a moment that I was able to just give her a hug through the phone. And that gave her hope, because she realized her companion was going to be there with her. It gave her a reason to fight, so the two of them can enjoy their walks together.
That was her support system.
That was her only support system. And she
never
knew
would
that
have
she was
brought
going
that
to
up
be
with her
okay.
doctor, I bet.
Say that again.
She never would have brought that up with her doctor, I'm
Absolutely.
sure. Yeah.
Absolutely.
Yeah.
You made it. You made sure that the environment was comfortable for her to say that,
Absolutely.
and that's really important. So I guess as we think about incorporating these conversations, we need to think about how we incorporate them and how we make them not just palatable but safe and comfortable for patients and families, because that's really important.
And the reason she couldn't afford the dog food is because of the cost of the medication. And therefore, we went a step further. We were able to find a pharmaceutical patient assistance program. She was able to get her medication for free for 12 months, shipped directly to her.
All of this is through this conversation.
All of this
which she would
started
not
with
have
one
had, as
conversation.
you said, probably with her physician. She probably wouldn't have had that
Yes, we got the application completed for the and only thing I did was we contact the pharma patient assistance program on conference call. She met all of the eligibility guidelines, make sure I screened her for income. After that, we contacted the doctor's office, faxed the application over, and she went directly to the doctor's office, completed her portion. I made sure she brought her a copy of her Social Security award letter for proof of income. We followed back up. She was approved within 4 days. It was wonderful. So
wonderful.
The work we do is very rewarding.
So one of the things that's important in terms of incorporating these cost of care conversations is making sure that we find the most appropriate person to actually have the conversations, to carry on the conversations, and that there be some continuity, because what you hear in January might be very different in June. So we need to think about that. And in terms of your own practices and so on, who would that responsibility reside with if you were going to incorporate it, if you have not already? Where do you think that logically would be placed?
So I've experienced a couple different ways of doing this. When I was in community health, we actually had financial screeners who were embedded in our teams. And so when we identified that a patient had a need, I actually could walk out of the room and put a green flag and move on to the next patient. And I'd send a message that said, I want you to meet with Mrs. Jones about this concern. And they would go in and talk, and then we'd huddle afterwards about what the plan was. And they were really valuable in our team, because if somebody was going to have a hospitalization or whatever, they could help them navigate that cost. I've also, currently in our residency program, we have embedded pharmacists, and they help us with our Medicare annual wellness visits, and they do the review of the medications and help us look at effectiveness of medication regimens, costs of meds, and if I have a difficulty getting a patient a medication, they help me navigate what the other options are, and that's huge. It's huge. And then from the ACO care management world, and these are all other people other than physicians who are having these conversations, and this is where I see that there's the most opportunity. We have telephonic care managers, and then we have paramedics who live in the region who actually go to people's homes, and they do a social determinants of health assessment, and they're the ones who I think give us some of the most helpful feedback about what the barriers to care are, and so those are the three options that I've experienced.
Yeah, I think that's wonderful, and I think to the extent that that kind of system can be set up where within a system there are people who can sort of meet the patients where they are and have those conversations in that way, that is terrific. I think what we need to be careful of is to say it's not the physician's job. It is part of your job. It's just like everything else, right? It's like managing their blood pressure. You're not the one who's filling the prescription. You're not the one who's necessarily doing the blood pressure check. That doesn't mean it's not part of your job. So the problem is in a less integrated system where it says, oh, well, we'll just pass that person off to the patient navigator. Then the issues that the person has around not being able to afford the medication or whatever it might be then become not part of the clinical issue. And as you say, planning my treatment or something like that, it has to be integrated into the clinical aspects of the care plan as well.
That's a part of as I see it, the complexity of all of this. It all makes so much sense. I mean, we talked about it this morning and people shared their experiences, and it's almost like common sense that this happens. But it's common sense that it happens in an orderly and organized way, and it's going to be different in different populations and different settings. But I think what you say is really important here, because we have patient navigators, and most places now have patient navigators, for instance. There might be someone that would be considered in some settings sort of a financial navigator, someone who does that same kind of thing, but it has to be across a system. So we'd have to be really careful about all of that. I think that's really important as we look at it. Just a couple of more things before we open up, because I'm sure there's some questions. Okay, just 5 minutes. What do you think are, because we now want to just move into, we know this is a good thing, we want it to happen, we have to figure out how it should happen. What do you think are the major barriers for us moving forward in terms of across the board sort of incorporating these conversations? Because it's this discussion that we're having here in this room today reminds me somewhat of the discussion around clinical trial participation. When you ask patients if anyone has ever invited them to be in a clinical trial, often they will say no, but then when I talk to physicians or researchers, I hear that, well, we ask pretty much everybody. Same is true when you talk about having a discussion around informed consent. Researchers always say, oh, yes, we have a process, because it has to be a document and a process. 90% of the people that I talk to about it, patients, say there isn't one. So we don't want that same thing to happen around financial toxicity. We want to be on sort of the same page with it. And thinking about that, have to think about how we make sure that if there are specific barriers, that we think about them ahead of time so that we can anticipate what might be the problem and work around it. So what are just maybe, if you think of one or two things that you think of as real barriers to us moving forward with this in a meaningful way? Because we want meaningful conversations. If we don't just want the conversation so we can tick off a box and say we did it. We want a conversation that will end in benefit for the patient, better care, better outcomes, not a box that we ticked.
Time.
Uh,
I think that's the biggest barrier.
And I think skill sets around having the conversation of the disadvantages to certain treatments, because that's where we fail in informed consent, is we assume more is better. And this conversation about, I hear that patients are fearful that we adjust treatment based on their ability to pay, but we really should be seeking cost-effective care, period. Yeah. And if something's optional or maybe not proven value, we need to inform patients that that's the case, because they will end up getting the bill somehow on that. And that is a fundamental cultural change that we need to make. And that downside to more additional care is we're not very competent at having those conversations.
Sort of like non-inferior care. We talk about non-inferior in trial. In a clinical trial, you might have a non-inferior drug. You don't think it's better, but it's not worse. It might be for a population that can't use another, and the same might be true in terms of care options. It's not inferior, but it's different based on circumstance. Okay. Does anyone have anything else you'd like to just very quickly share with us for questions? It's been a wonderful panel. You continue to be. Questions? Yes. Could you repeat that, please?
Sure. So I work across therapeutic areas, and in the oncology space, I always hear this conversation of engaging or trying to engage the patient and connecting them with wonderful organizations like PAP and with providers who take the time to have this cost conversation and integrate that into this shared decision-making dialogue. But I also hear it from other therapeutic areas where this is totally foreign. And I'm just curious from the panelists, from their perspective and their experience, is this common that other disease states outside of cancer or more serious, or maybe HIV/AIDS, I think that that's a common dialogue and conversation in some of these high-cost treatment areas. But I think it's also very important across all disease states to have this dialogue. And if we look at this problem much more holistically and try to make this a much common dialogue and discussion that we're having, so that we can tackle this and make this a very common discussion. But very curious what your experience, the panel's experience. I think all of you probably tap into other disease states as well.
Yeah, I can speak to from an ACO perspective, because we're moving into risk for entire populations. We're not looking disease specific most of the time, and we're really focusing on social determinants of health. And we've been able to reduce costs in Medicaid, Medicare, and our employee health plans and things like that, just by focusing on those social determinants of health. And that's a strategy that we've used that's been very effective. And like I said, it's not about a specific disease. It's about understanding who may be at risk, who may not be using the system in a most effective way, and trying to intervene and understand what the barriers to care are.
Yeah, I agree that I think actually focusing on a disease is maybe not as productive as it could be. For instance, I studied high-risk pregnancy. It's not even a disease. Pregnancy is a normal thing in life. So I think I was intrigued this morning, this idea that costs are a side effect of care, right? And so if you took that as a metaphor, it's actually, I think, technically true, but let's just use it as a metaphor. It's like, well, how do you treat other side effects of care? Well, you talk about them, or you prepare people for them, or you say, if you experience this, please call me. And also the fact that side effects are over-experienced by some people and under-experienced by other people. Some people don't experience a side effect at all from a given treatment. So I think if you maybe frame it in that way, all that behavior and language begins to come into play, and there's already kind of a little bit of a roadmap for how you deal with side effects and talk about them in care.
But I think the reality is that it often is siloed. Cancer care, particularly breast cancer, often there is that wraparound care. And I'm thinking of my own institution. Heart failure is another where they've got good wraparound care, but COPD doesn't. And so I'm a primary care physician, and I think this fits nicely in what I do as a primary care physician. But if I were to, think about my different patients, some, I think, have better access to some of these services through their specialists than others. I think that's what you were getting at. Yeah.
I guess one of the things that I'm thinking about as we get ready to end this session is, and you spoke to it, Amy, about we have to have realistic goals about cost of care. Talking about it. As a clinician, we got to have the time, because there are time constraints. I practice in a private cardiovascular clinic, and you heard Ms. Bridget talking about the time I spend with her, and one of the reasons I can do that because it is private. But oftentimes we do, as clinicians, face a huge problem with trying to get patients in and out. And it's not that, we do not want to discuss cost of care, but how can we, if we're going to talking about cost of care and getting more in depth, we have to be able to set realistic goals on how to get there, because there are certain clinics that is about volume and getting patients in and get them out, but we're still trying to do all this, to make sure the patient benefit in the end. But at the same time, you have to think about clinicians' burnout, which is quite high, and all of that impact care. So could you speak to that, I guess?
From my perspective, this is all fee-for-service. This is caused by fee-for-service, and looking at other models of care is what has to happen. One thing that we're testing in Western North Carolina is a direct primary care model, but looking at that for broader populations than insured. And some states have looked at a primary care trust where you create a fund. And so those primary care providers are out of having to document to get paid for fee-for-service, which is extensive, having to document all the details for all these insurance company requirements, and you take care of your patient and you document what's important. And you connect with them by phone, or if you need to go to their house, you go to their house. but you don't have to see them in a face-to-face counter in the traditional running people through the mill that is ineffective. We pay for group medical appointments. Other models of care, we have to get out of this mindset of how we've done it in the past is going to work, because it's not. And so I think we know that people have tried things that have been really helpful. We just have to be really insistent that we move forward with those different change models of care that make care better for people.
We're talking about a shift in system, a shift in the way that we do things. So this isn't this sounds like a small piece of it, and it is, but it's an important one which will require some other things shifting over.
Thank you all for a fantastic discussion. My name is David White. I'm a person living with kidney disease. I also chair PCORI's advisory panel on patient engagement, and I'm a patient and family advisor. And I wanted to know if you thought that patient and family advisors or peer mentors could play a greater role in this cost of care discussion. Patients, we outnumber you thousands to one, right? And we are like the most underutilized resource in the healthcare system. Now, I understand not most of us are able to have this discussion, but some of us like me who's been through this for 10 years, we've gone through the system and we can help. Have any of you had any experience using peer mentors or advisors to help, or do you think that might be a good idea?
We have a community health worker that works with, we're an ACO as well, much smaller than what Amy's a part of. But we found that she's been very helpful in helping us with some of our patients that are not meeting the goals for whatever reason, identifying those barriers. And again, as I said, a lot of times patients are much more willing to kind of have that conversation outside of the office. They don't want to bother their doctor. They may not even recognize that these things are impacting their health. And so having someone that can have those conversations has been helpful. I think getting back to Josh's point, though, it still needs to loop back to the care team and the provider. I don't think of that as somebody separate that I would delegate those conversations to, but to help have those conversations as part of the care team.
Yeah, and I think to that point, the community health worker or whatever you call that person should be part of the care team.
I do a model of care called group visits or shared medical appointments, where in my appointment the patients outnumber me, which is actually a great experience. So I learned about this over a decade ago from Centering Health Institute and we were having access issues. We were trying to get patients in, and just because the inefficiencies, we learned, well, you can try to do it in a group model. And so we developed a model for pregnancy, parenting, centering parenting, and then I do diabetes, but many of our other clinicians do other group visits for pain management. And some of those groups can be lay-led, so you can train patients to lead groups as well. And the benefit of that group, it's some of the discussion I heard earlier, is sometimes patients have better solutions to the problems that, most of the time they have better solutions than the providers, particularly if it's around navigating the health system and they have the same chronic condition. They can often help other patients in their group say, oh, I've tried this, and oh, did you know that this pharmacy has this discount? And they have a lot of that experience just from dealing with their chronic disease for a long time. And then the same thing applies to young women who have very small children or raising children and trying to navigate the care of their kids and their families. So that's an effective model. It's not an easy one to implement, but it can help engage patients with each other. I've had patients start to transport each other to appointments after being in groups. So it's a great way to have the community help you support patients themselves.
Oh, yes.
This is Jerry
question,
Krishnan.
I think. What?
Oh, no, we
have time?
Take a couple more.
Okay, yes, please. We've
Great,
got two people lined up. Yes, please.
This is Jerry Krishnan. I wanted to just weigh in on the discussion about the peer-to-peer mentoring. I do agree. I think that this is an enormous asset, and that we have not, as health systems, engaged in a more consistent, routine fashion. We have worked through a PCORI-funded project, actually, with a patient advocacy organization that is focused on COPD. They have a call center, and they also have a online social media platform that's moderated by other patients. And it's I've been given the ability to, I don't have COPD, but I was given the opportunity to see what is being discussed. There's a lot of things being discussed on these patient forums. And because it's moderated and it is linked to some other safeguards, the discussions are actually quite interesting. And I have used that information to figure out on our health system side, how should we be thinking about care? What are the conversations we should be having? And I've actually applied for PCORI funding to actually do some projects based on that. So I think what you've described is really important. I do want to second the comment made earlier that if we create silos of conversations, it's just going to make things more complicated. So I think probably the challenge is, why not leverage the talents that exist and somehow connect them and integrate them as a path moving forward, as opposed to learning from patient advocacy organizations and then within every health system trying to reduplicate those efforts. It's just not sustainable. So I really enjoyed the comment, and it's something maybe as a challenge for us in the health system side, is to think about how do we connect and integrate and broaden the collaborations in such that we're actually supporting the patient organization too. Maybe there's a way of doing contract work that they can serve as experts of the lived experience, and through some mechanism work collaboratively with health systems and health plans.
Someone else over.
Hi, I'm Amanda. I'm here representing NYECP. And we're actually working on a project along with New York AFP to integrate cost of care conversations with primary care physicians across our state. So I was just wondering, based on the feedback you gave, Rita, the doctors, everybody on the panel, are there any tools or resources that you found really valuable during training, to use for training or for patients during your integrations?
Absolutely.
That you could share?
Absolutely. There are several go-to resources that can be used. There's one on our patient advocate website. It's called the National Financial Resource Guide, and it's very user-friendly. And you'll put in the diagnosis, the age range, and you can click up the 4 topics. For instance, if that patient's needing help with pharmaceutical medications, rent, utilities, or if they're needing help with insurance premium. You can click as many of those as you want, and it'll give you a vast amount of resources. And we do have a resource team that regularly checks and updates the site. It's a really great go-to, and that's something that you can pass on to your patient that they can actually do on their own. And I find it to be, I use it myself, and it's something that we have in-house, and that's where I get the majority of the resources from. And those resources come into effect by myself and the other talented case managers that I work with. When we find resources, we share with the whole group, including our team that updates our database. Another one is needymeds.com, Healthcare Blue Book, if your patient wants to know the cost of what a PET scan, a CT scan is. If it's an uninsured patient, that's another great one. I did say GoodRx is another one. You want to contact your local community action agency. You definitely want to reach out to them. If it's someone who cannot afford their, just say for instance, they cannot afford to pay their utility bill and the medication at the same time, that's a great way to offset the costs. Needy Meds, definitely go to there, I just mentioned. If there's any assistance programs available or coupon programs, it's going to be listed on that website. And it'll give you the phone number of the program to contact.
Are there any other questions? No? Okay. Thank you so much. This has been a fabulous panel, and they didn't make me even remember their names. I didn't have to remember names. That's wonderful because they spoke up without request. So everybody, please give them a round of applause. of discussion. It's an exceptional panel, and I'm always sort of a next step, what's the action plan girl? So let's move on to that. Thank you.
Anyway, I wanted to ask everybody to join me again in thanking the panelists and the speakers. This has been a phenomenal day. And I'd like to highlight a couple of things that we talked about, and then also mention some of the next steps and some of the ways we'd like to keep you engaged with this. So a few of the things that I heard that we talked about, we were talking about how you really enact value-based care if you don't integrate cost of care conversations. And I think that's a really critical issue that we have to continue to explore. We're really talking about value cost as opposed to value versus cost. And most value frameworks have looked at value versus cost. I think that's critical. I think the other thing that that Kim Irwin was talking about most recently is that patients don't want to be reminded that they're poor or that they can't afford things. And there is an incredible stigma around money in this society, and there's an incredible unfortunate tendency to equate worth with how much money, human worth with how much money people are making. And we have to make sure that we don't perpetuate that, and that we figure out innovative ways of talking to people that don't have to do with reminding them of what they can't have or reminding them of what they don't have. I think the other thing that's really important, and we just started touching on this, and I'd love to see this as we go into our next steps, is we talked about, this panel was about integrating cost of care into the clinical workflow, but also the patient life flow. And so one of the things we started with, and Amy Russell started talking about, was innovative care delivery models and looking at reducing cost of care through innovative care models, and also improving outcomes like the group visits. And when we were together in Asheville, we were talking a lot about the group visits and the group visits that Amy did, and what you learned from the patients and what the patients learned from each other, which is also a way of lowering the cost of that treatment. I think the other thing that we learned from Shirley was that once she realized that there was no shame in talking to her care team about money, she was able to help other people get rid of that shame and help remove the stigma by going out into her community and really educating people. I think that we also looked at I did a bunch of things on value and cost. I guess that was something that really went up to the top of my list, but I think it's really, really critical because we've had, over the course of the last few years, value has been the buzzword. And we've been talking about value, we've been talking about value frameworks, we've been talking about patient preferences, but we haven't been using the and word, we've been using the or word, and I think we have to get to and from or. So I wanted to talk a little bit about next steps and then just make a few thank yous and one closing comment. So the next steps, this is a very large and far-reaching project, which I think you've all heard. There are many things that are going on in this project, both from the Patient Advocate Foundation, the National Patient Advocate Foundation, America's Essential Hospitals, American College of Physicians, and the 8 groups that were doing the research. All of these things will be many of these things will be available, and through Avalier's website, through our website, through America's Essential Hospitals website, Robert Wood Johnson Foundation website, ACP website, and post-Policy Consortium, we will keep you up to date on all the resources that as they are being published. There will be things that are primarily focused on clinicians. There'll be things that are focused on safety net hospitals, and there will be things that are focused very much on patients, caregivers, and advocates. And we all have slightly different focus, different things that we're focusing on in our projects, but they all integrate. For us, we just had a very, very soft launch of our cost of care section of our website, because a lot of what we're doing today will be integrated into this cost of care website, but we will keep on growing it, and we will invite your participation in that website. We've live streamed this on Facebook, so we'll send you all links that you can share with your networks. And especially if somebody wants to watch 4 or 5 hours of panels and discussions, it's really very exciting to do that. And so we will send that to you. We did our first webinar, which was with Yusuf Zafar and Susan Brown on the financial toxicity. Yusuf Zafar is a physician, and Susan Brown is one of our advocates who really talked about the working sick, which is a concept that we are all, those of us, I think everybody in this room is familiar with what happens with the working sick. We are also going to do a guide for patients, advocates, and navigators, which can be used by many people, and that'll be the end of our project. And there are lots of videos on our website, including videos of Liz and Tom and Rita. Amy's on our website. They're whole, Tammy's on our website, and everybody else will be on. Mary's on our website, so you'll all be video stars on our website as soon as we get that far. So I wanted to particularly thank. I wanted to start off particularly by thanking my colleagues who are here and my colleagues who are not here. This was an incredible effort by a lot of people to not just pull the policy consortium together, but to really focus on making sure on fulfilling our mission, which is to make sure that we do as much as we can to overcome barriers to quality, affordable health care. So in the room today, so I'm just going to thank the people in the room today, are Alan Richardson, or he was in the room, Alan Balsh, Caitlin Donovan, Shonda Cox, who checked you in, Chris Wilson, Donna Gwynn, Jamie Trotter, Kate Gallagher, Melissa Williams, Nicole Braccio. And I think I remembered everybody. I did alphabetical by first names. And I also want to thank very much our policy consortium members. Their names are on the inside cover. But we have had our policy consortium has been going on for 12 years now, and we have a group of sustaining members who have helped support this through all of those 12 years. And I just wanted to leave everybody with I guess, 2 kind of final thoughts. I think that, one of the things that we all know but we have to say as explicitly as possible, is that financial harms can have as significant of an effect and consequences as physical harm. And I think that if we don't integrate all of these conversations into our care and our health and care, we are not going to ever we are not going to improve the health of our fellow community members, fellow citizens, and family members. And then I think that the one thing, and it just keeps on sticking with me from the beginning, from Suleika and from Tom, is just to always make sure that we know and that we always focus on the fact that everyone has the right to live. Everyone has the right to afford to be able to live. And we cannot have any kind of value care, any kind of effective health care in this country if people can't afford to live. That is a basic right, and that's what we are all working for. So thank you so much for coming. I look forward to continuing this conversation. I look forward to keeping everybody engaged and apprised of all the various different work that we're doing. And I want to just say once again, thank you so much to Robert Wood Johnson Foundation for their incredible vision in this project, and making it something that's lasting and that's ongoing, and that is an ongoing partnership and an ongoing not even, it sort of transcends an initiative, an ongoing value that we're trying to embed into our healthcare system. So thank you very much.